That one you got to tell us.
She wants to come with the mommy. Kenya, but if you have to do another side that water park. You see from this oil about my bike, say and why then it's segmentation? So if you have we just in now you for one straight of beds.
Because they can host them.
And now they are bungalow over that one now we go be mana the Kenya. Network from Epa, ESU from Roma,
One, two, three, sound. Boom, 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 boom.
Da ita suka je gidan hajjiya, ca ne su cire kayan ciki. Sai a tsadansu. da headphone dan Allah bacci yake iya ba ma ke je ki ce wa abba dan Allah wai eh an ce ina su ke yanzu za a yi wannan
Mai ke saka wa
Na yi muting kenan ai, ko?
Good morning, everyone. Um, Apologies for the delay. These are due to some unforeseen circumstances, but I think everything is set now. We can commence the webinar or the workshop proper. Good morning once again. My name is Mohammed Laliu Abba, a senior lecturer at the Department of Physiotherapy, Bayo University, Kano. Bio specialization, yes. I have my area of interest or specialization, which is neurological physiotherapy. And second area of specialization or interest is geriatric physiotherapy also. So today, once again, we're here again. Last year, I think around 9 months ago, we had a similar workshop, but this is going to be more detailed than what we had last year. Last year was a presentation, was a 1D presentation, which everything has to be compressed. And I remember we are unable to complete many aspects of it because how this particular topic, how bulky it is, how voluminous it is, but since it's now divided into two, we are going to be having a part this week, and by God grace, the following week, next Saturday, we're going to have the other part. So I systematically divide it into two, so that we'll take some parts today. For example, the pattern I divided into two, because we can't take all the patterns. At least we'll take the upper limb patterns, we'll take part of the lower limb pattern, we'll take the pelvic pattern, then we'll take the agonistic techniques of the PNF. Then the following week we can take the antagonistic techniques, then we can take the realization techniques also, plus other things I've mentioned. I hope time will also permit us to take GATE training or GATE rehabilitation using PNF. We'll also take math exercises. This is a lot to take, but I'll try to see how we can get some things out of the highlighted synopsis. So I've already mentioned the synopsis, but this is summary of what we'll be looking at. We're looking at the introduction, which I've already made introduction now. We're looking at the brief history, how the PNF was developed. Everything we do, we need to know what are the reasons those things came into being. Are they by accident, or there is a particular reason, and what happened over the period of time? What are the changes that occur? Then the philosophy of PNF. These are what guide someone in the application of PNF. Then assessment procedures. Even though there is a section which I added, we are going to look at documentation in a PNF, which is very, very important. Then we'll be looking also at principles. Then we'll be looking at the techniques, which I have mentioned, the agonistic and antagonistic, but today we'll only be looking at the agonistic techniques. Then we're looking at the patterns. We'll look at the upper limb patterns. We'll look at the scapular patterns of upper limb. Then we'll look at the pelvic patterns of the lower limb. The combination of of patterns of the upper limb. Then we'll look into documentations of PNF. Why I added especially documentation is just to draw attention. I remember last year and the previous years, I was having this seminar or webinar or presentation. I tried to call our attention that first of all, the best way to address this approach is to say PNF concept. Most of us will be saying PNF technique. We'll be saying PNF this and that, PNF stretching. And I remember I brought some articles that I even see academics have been publishing papers with the terminology PNF stretching. Stretching is just like 5% of PNF. So when you say PNF stretching, is you are already narrowing to what you have done. You are already narrowing what you have done. So you are not carrying along many other things that you had in mind. By just looking at the topic, looking at your intervention, people that know the PNF will believe that you only pick one aspect of it and you did. But what you had in mind or what you go in to see is entirely different thing. You don't see even stretching sometimes at the content of the interventions. So there is this a lot of the issues with the naming. So the best way is to say PNF concept, proprioceptive neuromuscular facilitation concept, because it's a concept which encompasses a lot of things. It's something that has been that was developed over a long period of time, and we will see through the history what are those things that came in, somewhere added, somewhere removed, and so many other things. Yes, that's from the terminology. The PNF concept instead of PNF stretching, or instead of saying PNF technique. Because if you say PNF technique, you also mention one aspect of the PNF that you have applied. So starting from nomenclature, yes, PNF concept is the appropriate term. Then why I brought up this issue of documentation is whenever I come across folders, whenever I'm managing patients, I used to even jokingly ask my colleagues, I'll see a documentation, something similar to what we can see here on the slide. You'll see PM/PNF. This is what we always see as the documentation, PNF/PNF. So does that mean passive? That's what I believe. PM. That's what I believe is passive movement, right? That we does it mean we did PM passive movement /PNF? Or we mean that PM is synonymous to PNF. And I will now jokingly ask the individual that I'm working with, I will say, okay, did you do PM or did you do PNF? The person will say, okay, it's PNF. I'll now ask that, okay, you have done PNF, what pattern did you apply? You say, we did diagonal one. Well, we did the upper limb pattern. I'll say, okay, which diagonal of upper limb pattern did you use? Then that's when you start saying, okay, he didn't even think of it. Or maybe doesn't even have idea of the diagonal, that in each part there is pattern, upper limb, there is trunk, there is pelvic pattern, there is scapular pattern, there is lower limb pattern, there is a trunk pattern, there is a combined upper limb and neck. For example, there's combined lower limb and pelvic and all those things. Then I would ask, okay, let's forget about the pattern. What technique did you apply? Then that would be more confusion. What technique? It's something we've been saying, PNF technique. Okay, so what technique do we apply? Because we have to apply a certain technique. We want to improve, we want to initiate movements, we want to bring about coordination, or we want to improve strength. What do you want to improve? There are various techniques for that. In fact, we even want to relax a muscle. For example, static muscle, where there is pain, all those things, the relaxation techniques come in. So then I'll ask, okay, what technique was used? Then that's when there'll be more confusion. Then I'll ask more and more things. So that's why I believe I should also bring this in, this PM, PNF. That's why I added the documentation. to the topic, especially today, so that we'll look into the various sections or various concepts of the PNF. Then we'll now know that, okay, when we want to document, you have to make sure that so things are in place. Then that's when it's showing that you have appropriately administered PNF. Then there's also an assessment document that was developed by Maggie Knott, which we are going to look at by the God's grace towards the end of the presentation today. I've taken it to the last aspect so that after we have gone through the whole concept, at least some part of the concept, so that when I'm going through the documents, we'll now know when I say technique is agonistic technique or is antagonistic technique or is dynamic reversal or is rhythmic initiation or is the diagonal 1 into flexion or diagonal 2 into extension. We will now understand what we mean by that documentation. Even though there are some sections which is going to be by God's grace next week, that's especially about gates. There's a section which is talking about gates and also math exercises in the document, but I'll try to explain some of those things before we have the lecture next week. So this is just the introduction. So we start by, yes, PNF sounds is just to douse the tension in PNF. I know it's always, sometimes you even receive lecture or you read PNF, you even become more confused than you are, because that's when you begin to learn other things that when you now see them, then you begin to think, what are those things? So people need fun. I think PNF is a fun thing, even though it's very confusing, it's difficult, but I believe it's also fun. But we'll see over the next hours before the close of today. We will now see what I'm saying. So, well, let's look at the brief history. I've just mentioned Maggie M. Knott, which I've said she has developed an assessment and treatment document, which is being used for documentation of treatment of PNF. So not just documentation, also for assessment, probably diagnosis, and as outcome measure, and also documentation of treatment. So this PNF started when Dr. Herman Kabat, who is a physiologist, a medical doctor, they collaborated with Maggie M. Knott and developed the PNF. But initially it was termed proprioceptive facilitation, until later now, over the years, it was renamed to become PNF. So this is a picture of Kabat at his old age. Yes, then we have Maggie Knott at a younger age, the picture. Then these are the PNF was later named proprioceptive neuromuscular facilitation. So you can see the addition of neuromuscular there, which was done by Dorothy Voss. This is Herman Kabat at his younger age, and this is also Dorothy Voss. They were administering PNF. You can see this is upper limb pattern, lower limb pattern in the opposite direction. They are combining the two. So this is more advanced, not just upper limb or lower limb in isolation, but they are also combining the various body parts together. Then in 1946, a Kesa Kabat Institute was established in Washington, D.C. And this institution came about because a wealthy industrialist by name of Henry Kesa had a child who had poliomyelitis, and he's wealthy, he's well-to-do, he has all the funds. That's when he observed, he heard about what Kabat and his colleagues were doing. And that's when he decided to invite them to set up institute and fund the institute, just to make sure that his child got better. So we could see how this thing, anything you have all the knowledge and put it in writing and other things. If there is no fund, then probably won't have a PNF. Maybe something else, but yeah, maybe something else, or maybe not, maybe much later. But yes, we have the PNF because the Henry Kesa had a child with poliomyelitis, and he now invited them and found them set up institutes to make sure that they are conducting research, they are developing the treatment so that his child will get better. So that's why when you look through history, you find out that the development of PNF, the early conditions that were used, the early patients that received PNF at the beginning were poliomyelitis, then followed by multiple sclerosis. So yes, still going through history. Yes, the center moved from DC to California in 1947, and that's when they started developing treatment techniques and procedures, which I've mentioned. I've mentioned earlier that you cannot say PNF technique because you are just narrowing the PNF. You say PNF concept because technique is there, procedure is there, pattern is there, many other things are there. So you say PNF concept. So that's when they begin to develop the techniques, then the procedures. Then all these techniques and procedures were developed as based on the principle of Sir Charles Scott Sherrington, which we are very much familiar with. We know the principle of reciprocal inhibition. We know the principle of phenomenon of irradiation, which we are also very much familiar. Successive induction and so on. So these are the key. There are other principles but these are the major principles based on Sherrington. We are very much familiar with Sherrington, who is a physiologist, also a medical doctor that had played a lot of role in development of neurology over the years. So many principles we see, so many things are based on his own findings over the years. So still going through the history. Another institute was, so they are now expanding. So they are being well received by the community, medical community, and the populace also. So they are bringing up patients, bringing up so there is more demand. So they open other centers. The first one was in Santa Monica in California. Then that was when, in 1953, Dorothy Voss joined the team, and that's when they now renamed the proprioceptive facilitation. That's when they added the neuromuscular into it. So that's when they have the 3 terms: proprioceptive neuromuscular facilitation, which I mentioned earlier. That that's when Dorothy Voss joined them. In 1956, that's when the first PNF book was written. And later on, a lot of things were evolving. Then first course was introduced in the 1950s. After the first book was developed, then courses now came into being in the United States. Everywhere, professionals now come and they train and they learn about the PNF because there's increase in demand. Patients will ask for, okay, we need the PNF. Do you have then there's a widespread of knowledge. So it's spread even not just in the US, it's begin to go outside up to Europe. And first course in Europe was taught by Maggie Knott herself in the 1970s at Switzerland. Then at 1978, Maggie Knott passed on, and IPNFA, that is the International PNF Association, was established in the 1990. And this is the institute that give authorized institution to give international certificates for people who have attended courses, just like what I did. I had my certificate, IPNFA course at Krakow in Poland, which is some years back. So they authorized this institution to give this training and also this certificate. It's a very intensive course. It's a course you had for weeks, from 8 to 6 every day. and you had the exam at the end, then you have to pass, then you get the certificates, then you go to further advanced and many courses. So I only had 1 and 2, but there are about 3 or 4 courses. After after the basic 1 and 2, there are many more advanced courses, but those courses are for people who want to go and give training. I mean, they want to give the IPNFA certificate, because for you to have those certificates, you have to go for further training. But for somebody to practice this in class and all those, the basic 1 and 2 are very much okay. Yes, so this is just in brief about the history of development and how it's started. So we look at the definition. Proprioceptive means stimulating sensory receptors, which receive information concerning motion and body placement in space. Then neuromuscular, that's by activating the myoneural tissues. Then facilitation is to make things easier. That's just the essence of the PNF. There is weakness, how do we improve strength? There is pain, how do we reduce the pain? There is tension, how do we relieve the tension? There is many of those things is to facilitate, to do things easier, even though learning it is not that very easy, but at the end, when you learn it, it makes things very much easier. So this is overall the concept, and like I said, the gait rehabilitation and the mat exercises and the other patterns and the techniques, we might take them next week by God grace, but we'll concentrate. This is the whole philosophy. This is the whole concept, sorry. The philosophy, the basic principles, basic techniques, movement patterns, gait rehabilitation, mat exercises. There are other things such as chest physiotherapy, there is facial PNF, and so many other things, but I don't want to go into those other, they are very much complex things. So these are so starting from the philosophy, there is always a philosophy guiding many treatment approaches, many things we do in the clinic, how we handle patients, how we administer this particular treatment. So first, the philosophy is there is always positive approach to patients in the PNF. Always positive approach. What does it mean is that positive examination and evaluation. We may see that some of this philosophy may look the same, but one of the things is that, yes, we always look at the good side of the patient. Patient will come, we only look at the patient, that patient cannot sit, cannot stand, cannot even do anything, and you just be thinking that there's no, but what PNF is always looking at, what is that little thing you can pick from that patient and improve on it. Improve today, tomorrow, next week, next month, and so on. That is what they always look at. Sometimes we always look at what patient can, we always ask, we also always say patient cannot sit, cannot stand, cannot do this, cannot do it, cannot that. But we tend to forget what can they do. Those small things they can do are what will help us to improve on the patient. That's why we have the irradiation, the induction, other places that are functioning can help other body parts. So positive examination and evaluation, we go with a positive mind that we're looking for something good. Not just all the time we're looking for what the patient cannot do. Then, yes, we look at what the patient is able to perform. There is pain-free. When there is pain, you have to change the procedure. You have to look for alternative technique, or the same technique, you have to look for alternative pattern, or both of them, you have to look for alternative position. Is it in supine line? Should you do that in a sideline? Should you do that? Different ways you have to look at. There should be little or no pain. The pain should be minimal in PNF, yes. Because there are also some other techniques that will help you in the management of pain. If there is pain, then you now go and use some techniques, manage the pain, then come back. That is what is always, then strengthening his motivation. We always look at the good side. Motivation, what he can do is which will always motivate patients, not what he cannot do. Sorry, I make a transition. I even forgot it. It's for a long time. So, mobilization of patient reserve. Like I said, they might look the same. So those little things we have observed that the patient is able to do, we should make sure that those are the things that we work on for that patient to improve. Those improvements may spread across other body parts, across other joints, across other muscles, and so on. So we do that by make sure the patient is actively participating. In PNF, patient has to be active all the time. Even if it just required that patient to be watching what you are doing. You are mobilizing the patient passively. He has to be following you to see all the movement all through you are doing. He should be observing it from the beginning to the end. Or you should be communicating. You should be talking to him. You should. All those things are very, very important. We are going to be looking at those things in the procedures. So it's very important that the patient must participate actively all the time and should be intensive, multidimensional. Like I said, changing position, changing the activities, changing the pattern, changing the technique. You have to look for a way that those things must be done easier, without pain, without hassles, without problems. So the training program, yes, you make sure the person goes back home and continue with some activities by himself, by the family, by maybe home visits, by the physiotherapist, by whichever way the patient should also continue with those things. Then functional thinking. Some of the things that people have been criticizing PNF is that it's not functional because of the rigid nature of it, that it has to be in a certain pattern. The D1, D2, it has to be diagonal, all those things. So people always criticize it that it's not functional, all those things. But when you look at it closely, is functional. And you also have to make sure that what you are doing is also functional. That is it. Because like I said, over the years, there has been a lot of evolution. There have been a lot of changes. Even currently within the school of thoughts, within the PNF organization, there are still people in the belief of thought that this PNF shouldn't be diluted with all those things that are coming up recently, task-oriented training, all those things. But some believe that it should be functional. Yes, you should make sure you want somebody to be doing the one pattern, then you should give him probably a comb to be using it, or you give him something to be very much functional. So everything should be goal-oriented, should be goal-directed. What are those things that the patient wanted to do? He wants to be brushing his teeth. He wants to be, he wants to make sure he's going up and downstairs. Those are his goals. Or he wants to make sure he can comb his hair. He wants to make sure that he can bath. Those are all those things. So what are the movements that you can facilitate to make sure that patient is able to achieve those goals? So that's why it's important to ask those goals and document them also. So that's why we need to look at the level of impairments, at the level of the function, at the level of the activity, and the level of the participation, what the patient can do. You know that there is patient, you have improved the strength, but has that strength translated to the patient, or you have improved coordination? Has those strength and coordination translate to the patient being able to take water into his mouth? He's not able to do that. That's your strengthening and your coordination is not reflective. You have to align them with the activities. Then can that patient able to go out and participate in many live social activities? That's also another thing. Patient can walk, but you need to make sure that he has a community ambulation. He can go out, he can attend wedding. That patient can go out to visit family members and many things. So it has to be functional, goal-directed activities. Then holistic approach. Yes, we look at the patient as a whole, even though we are looking at individual impairments, activities. Then we also look at the patient as a whole. What is a human? What is his role in the society? What is his role in this community? What is the role of this individual in a place of work? Has he retired? Has he been sacked probably because of the condition? Because there are no laws guiding all these things. Companies can decide to probably sack a stroke patient because they thought he would never be useful. But does his role have to change to something else? What can you do in what is the role of the what's the role of that patient? Well, probably is a mother and she fell at the patient with multiple sclerosis. And when I asked her that, what do you want to do? She said, I just want to carry my baby. That's the greatest concern. So imagine you just work on gates, you just work on all things you want to do, and she go back home, she cannot carry the baby. So all your targets have to make sure that, first of all, let her be able to carry that baby, even if it's in lying position. She's able to hold that patient. You graduate to sitting position, you now graduate to chair, probably, you now graduate to probably standing. But along the way, you're also managing other impairments, also making sure she's having other activities. She said first of all, she wants to make sure that she can carry the baby. She can take her phone and use it. Then she can cook. Those are simple things that she have mentioned. And those are the things that we say, okay, let's target these things. Day in, day out, we plan the management, and at the end, she was able to do that. So if we don't look at these things, patient will be coming for a very long time and we will be missing out on what they are doing, on what they want to achieve. We have to align with their goals. As a whole, as different impairments, their role as a whole in the society, in the community, somebody will just say, I want to perform ablution. He doesn't like people doing ablution for him or her. Probably the person wants to make sure that he's standing to pray. The patient wanted to see that can go to the church, can go to the altar, can kneel down. So many things. So those are the things that we look at the patient as a whole also. What is the role? He's a father, he wanted to do this and that. So it's a human nature that we just want to see any deficiency in our life, in our role, because we feel many things can change or can happen to us in that particular area, in that particular aspect of our life. So we also use these stages of motor control and motor learning, which I believe we are very much familiar with the stages of motor control and motor learning also, how all these things come into being. I won't take much time. Then the assessment, I won't take much time because we are looking at documentation. Yes, this is a sample of what the McGee developed. I have the document. I will circulate it later, and I can also project it. We'll see the content. We'll see also it's about 11 pages document, but we'll just pick out some very key aspect of it. Here's just a summary of it. So we'll now start with apart from the philosophy, we'll now go into the principles. So the principles, they are supportive at guiding the motion by grip, appropriate manual resistance. It's help patient. It's helpful to patient in obtaining coordinated motion through timing. Yes, there is different timing for emphasis. So many other principles that will guide us. So sometimes you see procedure in some text or in some document, you see procedure as a separate, you see a procedure as a separate aspect of PNF. Sometimes you see procedure under principles. For example, if we look at the synopsis I gave, you could see that under the concept that yes, you could see that we have basic principles and we have techniques, but we could see here that I've not mentioned the procedure because we say it's under the principles. Yes. So what are these basic principles? One, the stimulation of exteroceptors. We have to stimulate the exteroceptors. Then we also stimulate the proprioceptors. Then the procedures that will guide us through in the management of the patient. So let's start taking them one after the other. First of all, how do you stimulate the exteroceptors? Of course, they are the skin and other things. They are on the skin. So it's by grip. How you touch the patient, how you have a grasp of the patient matters. We know there are different grabs. We have the power grabs when you hold something tight. Yes. We have the hook when you're holding something like a lamp. You have the spherical, you're holding something very specific, and so on. But this one is usually, majorly all the time, we have the lumbrical grips, as we can see on the picture here. The lumbrical grips, that's how you hold the body part, that's how you hold the limbs or the fingers while administering the treatment. So it is termed in the form of manual contact. Yes, how you hold the patient matters. And also stimulating this also could be contact with the environment. Yes, that is, so these are the goals. Sorry, let me go to the goals. Then before coming back to the explanation. The goals of the tactile stimulation or the exteroception or exteroceptors is stimulation of patient skin receptors. Like I said, the grabs, the touch. Yes, it stimulates the receptors. Then facilitation of direction of movement. By holding the patient, you'll be able to direct the patient that this is where you want him to move in, so that you not just be moving randomly, not in the order of you want him to move. Then the patient feeling protection also. When you hold the patient will not feel that he should just carry his hand and throw it, and he will now hit something else. You'll get injured. It's that sense of protection. You are holding him, then he feel you are standing, you are in lying position, you are in a sitting position. That sense of protection is always there when the patient is being touched. You feel that. Then possibility of applying resistance also. When there is need for resistance, also that grip will allow you to give resistance. So we have auditory stimulation. This comes usually with verbal contact or command. You talk to the patient. He's doing something, he's not doing it very well. You now give him instruction. Or this is how you wanted him to do it. You give him the instruction for him to understand and do it. Or he's doing it along the way, he's now losing direction. Or he's losing the strength or the tension. Or he's not doing it well. So that's, or even some kind of motivation. Do more, go on. Yes, faster, or slower. More strength. Please don't lose the tension. Okay, relax. All those things. That's why I say it's active participation. Patient cannot just lie down and you just do movements and that's patient to go. That interaction also help that is actively participating. And that's why at the beginning I said, I showed that picture of PM, PNF. I think by the end of this course today, if we are writing PM / PNF, I think it's going to stop. So what is the goal of the auditory stimulation is to draw the patient attention on the motion that is expected to perform. Just like what I said, you just give a command, hold, or relax. So something like that is just to stimulate the patient or to make sure he's doing the right thing. And you also try to observe. You as a physiotherapist also, you also, maybe some will not talk, some will not express on their face, but you could feel is grunting, maybe pain and some other things. So you also make sure that you also are doing the right thing. So commands, sometimes there could be preparation, there could also be action, like I've said, then there could be also correction. You want to make sure he's doing the right thing. Then visual stimulation. We have the tactile, we have the auditory. So all the time you are giving treatment, you have to make sure that visual you are vigilant, you are seeing what he's doing. The auditory, you make sure you are talking to the patient about instruction, about what he's doing, about the instruction for him, what you want to do, about making sure he's doing the right thing. If he's not doing it, how do you correct him? So that auditory is coming, that tactile has to be there. That auditory has to come. Then the visual, you also watch how he's doing it. You also watch if there is he's not paying attention. His attention is somewhere. Probably he has some attention problem, maybe cognitive impairment, or yeah, or or there is distraction. TV is there, people passing, or many other things. So you make sure he's paying attention. So related to his body, you make sure he's doing the right thing, he's in the right position, he's doing the right movement. You also make contact with him. You see his face, you see his eyes. He's not showing any sign of discomfort or any sign of pain and all those things. So yes, then visual, yes, still on the visual stimulation. It's usually just like what I explained. We make sure that the patient is doing the right thing through the visual contact, through observation of what he's doing, through also seeing where his attention is, also where his focus, where he's looking at also. So how do we apply this visual stimulation? Patient follows motion of the body. Yes. Patient's observation of gradient resistance and pain. Just I've explained all this before the slide. Then the stimulation of proprioception. First of all, for the stimulation of proprioception, there should be resistance, of course. Yes, the resistance should be manual contact, or it should be from the environment. The resistance can come from your hand. You are giving graded resistance, and it's called optimal resistance, not resistance that the patient cannot, unless you are applying a certain technique that will not require movement. Yes, but this resistance shouldn't be that the patient cannot overcome it. So manual contact, resistance coming from the physiotherapist. Then environments, you could use a TheraBand, we could use springs, we could use all sorts of, we could even use the wall, we could use the floor, we could use the couch. All those could be used as resistance. But when applying resistance, it's always, yes, there are different types of muscle contraction when applying the resistance. The eccentric, concentric, the isometric, all these three, they come. These are what give meaning to the techniques. So when we come to techniques, I will discuss this further. These three different muscle contraction are what give meanings to the techniques, because that's when you know that you are applying a combination of isotonics, or is a technique that you're applying for dynamic reversal, or all those things. So, but all the time, the resistance should be applied in 3 dimensions. The patient will come to the pattern. The patient, for example, is let's say shoulder or upper limb pattern. The patient is probably is going into flexion. So he's not just flexing the shoulder. The patient is also going into external rotation, is going into adduction. So the resistance should make sure that it's applied to not just flexion. The resistance is applied to the adduction and the external rotation. So that's why we make sure that it's going into those 3 dimensions of movement. So the resistance can now spread across the 3 dimensions of movement, not just going into flexion. And the resistance is also the flexion. So in the pattern, we know that is in 3 dimensions. So the movement. So that's what it means here. So I'll discuss the types of muscle. I'll also discuss the 3 dimensions. Sometimes you could give traction to make sure that the muscle contracts better, or you could give approximation before going into the movement. You approximate, then that's when you now see more strength or more power of contraction of the muscles. So, like I said, the resistance should be optimal, properly adjusted resistance to the patient abilities. Yes, different patients will have different abilities, then applied against all components of movement. Like I said, it's applied across all the components. It's not just going into flexion. So it's not just going into flexion. It's going into flexion, external rotation, and adduction. So the resistance should be across all the 3 components. So possibly in all muscle contraction, be it the rhythmic, be it which muscle contraction you are applying, then it should also be so. Then, what is the goals of this manual resistance? Facilitation of muscle contraction, improvement of motor control, then improvement of motor control, improvement of sensation and motion awareness. Then increase, we know when you give resistance, overall what we need is most of the time is strength. Yes, so that's overall. But it's also other things like I've mentioned by the side. So still also a simulation of proprioceptors, we have stretch. Like I said, you could give stretch. We know that stretching sometimes will improve the muscle, more oxygen and all other things coming. Then it's preparing also the muscle. When you stretch, you are telling the muscle that contraction is coming. Then it get prepared ahead. Then you see a better contraction. So there is also stretch. This stretch comes in different ways. And one is initial stretch. Before you contract, before there is movement, you give stretch at the beginning of the movement. That's what's called initial stretch. So when you want a good contraction, then you stretch that particular muscle or that particular joint, you give a stretch, just a little stretch, then you see the muscle will now contract better. Or you are going through the movement, then the patient is now losing the tension. Then you'll be stretching all through. So that's why you see stretch, initial stretch, or you see restretch. You'll be stretching while the patient is going through the movement. So that is also, then we have the procedure. Under the procedure, we have movement patterns. Then we have timing, which I've mentioned. We have the body mechanics, irradiation and reinforcement. I'll only talk about, okay, we'll start talking. Okay, let me talk about timing here. I don't think I have them in the slide, so let me just talk about timing, body mechanics, and irradiation, because I can see we are going straight into the patterns now. So timing is the sequence of movements that you do. For example, you are coming into D1, diagonal 1 of the upper limb, going into flexion. For example, you now know that there is a flexion, there is a adduction, there is external rotation, right? Those are the first sequence. Then what follows is the elbow, the pronation, supination, the wrist, the fingers. I don't take us there because there'll be a lot of complications. So that is the timing. What should come first? You make sure you are following that sequence. This is the first thing, second thing, third thing, fourth thing, and till the end. While also reversing, how do you reverse and go back? That is the normal timing. Then there's timing for emphasis. You observe that the problem is supination and pronation. Then you just concentrate on that. You apply a technique there, and you just emphasize on the pronation, supination. While you are coming through, you observe that there's a problem with supination and pronation. I told you that you have to be adjusting, readjusting, and make sure what is the best for the patient. So you come through and you see there's problem with pronation and supination. Then you go back and you now begin to emphasize that, let me see the pronation, supination improve. Then you only concentrate on it. You apply a technique which you feel is a technique that will improve that particular impairment. You emphasize on it, so that's the timing for emphasis. You only go there. Okay, what are the sequence in that movement? Maybe just 1, 2 joints, and just emphasize on it. You don't have to include probably the shoulder, you don't have to include probably the elbow. It's just the wrist maybe and the fingers. You only concentrate on that. So that's timing for emphasis. You have the initial timing and you have timing for emphasis. So we have to master the sequence of movements that's coming from shoulder down to the fingers, and from fingers down to the shoulder in the reverse, which is the extension, flexion and the extension. So that is the initial timing, normal timing and timing for emphasis. Then the body mechanics we know is our position. The position is always, you are also always in diagonal, in the direction of where you want to give the movement. That is easier because you end up with back pain, you end up with, you won't be able to give the appropriate resistance, or even on end of maybe tripping up and fall, maybe falling down. So that's the body mechanics. Make sure the patient is lying properly, is the best position that you can give that particular pattern and technique. Then also your own position too. You can make sure you facilitate it. The facilitation term is there, that you are doing it as easy as it's supposed to be. Then the irradiation and reinforcement. is usually, I don't have any slides there on it, so I'll just explain, is usually using other body parts to create movement in some other body parts. Most times, this is very much advanced. You will see upper limb movements. The resistance you apply will initiate movement in the lower limb. Yes, you see many at times such things happen. Or in the lower limb, you initiate upper limb movement, or in the trunk, you initiate lower limb movement. So that's the irradiation and the induction. And that's why I say, if you remember the what do you call it? The principle of Sherrington's I've mentioned at the beginning. You see those things, successive in the induction and innervation and so on. So we can go to the patterns. These are the these are the very challenging. Yeah, we can see on the slide there. You can see your clock there, and we can see the numbers 1, 2, 3, 4, and so on. So these patterns were derived from how it was observed that people move, how people walk. Normal gait pattern. When we walk, we have this pattern of movement. Even though it's not like too obvious that you have the flexion, you have the extension, you have the rotation, but if you take it bit by bit, you see those movements are there. So the PNF patterns, like I said, they are in 3 planes. They are in sagittal plane, they are in coronal or frontal plane, there's also in transverse or rotation. So that's why all the time you are given the pattern. It's not just you take the arm into flexion. It's not just you take the arm from flexion to extension. There is a spiral movement, spiral nature of movement. For example, like I said, going into flexion, you have flexion of the shoulder, you have adduction, and you have external rotation there going on. So all the 3 are combined. So whenever this movement is occurring, you want to make sure you're doing it right. You have to make sure that these 3 movements are going together. So we have various patterns, upper limb patterns, lower limb patterns. We have the scapular patterns, we have the pelvic patterns, we have the trunk, then a combination. I've earlier showed at the beginning that there was a slide by which I showed Hamann, Cabot, and the Dorothy Voss that were giving a combination of upper limb and lower limb patterns. So it's not just giving upper limb pattern, lower limb pattern. You can also combine. You can combine the upper limb. You can combine the lower limb. You can combine the lower limb and the pelvic. You can combine the neck and upper limb. You can combine upper limb and lower limb. You can make various combinations. It depends on what you want to achieve. Yes. But I believe that will be for very advanced patients that have advanced recovery. Those are people that can be able to do that. But those with a lot of problem with coordination, they won't be able to do much of this distance. So let's start looking at the patterns one after the other. For us to understand the patterns better, there are 2 diagonals. The movement are always in diagonal, of course, as we have mentioned, they're in diagonal. But there are 2 diagonals. There is diagonal 1. That's the first diagonal. Then diagonal 2, which is the second diagonal. So they are termed D1 and D2. But that D1, there's always a movement of going and coming back. So that's why we have D1 into flexion. We have D1 into extension. That's always the confusion. We don't just have D1, we have D1 and D2. That D1 we have into flexion and we have into extension. The same thing with the D2. We have into D2 into extension. We have D2 into flexion. So the same thing. D1 into flexion, D1 into extension. Because if you go, you have to come back as well. So, but it also depends on your interest, where the impairment is. You want to, is the flexion that you have problem. Then you go into the flexion. Then you know which technique are you going to apply. Or is both flexion and extension they have problem. Then you know, okay, which technique should I apply for the management? Is it weakness? Which technique should I choose? Is it strengthening? Which technique should I do? Yeah, you have weakness, of course, you go for strengthening. Is it coordination problem? Which technique should I choose? So that's why I said we don't just say, I'm still taking us back. We don't say PNF technique. We say PNF technique. We are just talking about one aspect of like 10, 15 things under PNF. So we just say PNF concept. Unless we now want to document, which I said we are going to look at documentation, which we are no longer going to be seeing PM/PNF. Well, so you document PNF. Now we will now begin to know that what technique, what diagonal have you used? Which diagonal into which direction? Which technique have you used? Which pattern, which technique, and so on. So we have diagonal 1 and we have diagonal 2. We have diagonal 1 into flexion. We have diagonal 1 into extension. We have diagonal 1, diagonal 2 into flexion. We have diagonal 2 into extension. But to simplify things, how I was taught also, we started with the pelvic and the scapular patterns. I think it's easier to understand, and it's easier that we can apply some techniques also before we go into full stretch upper limb or full stretch lower limb. So we have the scapular pattern. This scapular pattern was extracted from the upper limb pattern. If you take, for example, I think maybe I have to activate my Kokomo. We use the camera to show. Well, let me activate my video. So when you have the D1 into flexion, diagonal 1 into flexion, which you have shoulder flexion, in adduction and external rotation. But you also have the scapula also gliding. You have anterior elevation of the scapula. So this scapular pattern is just a small aspect of the upper limb that was extracted. And it has its own uses also. When you look at dynamic stability, the movement of the upper limb depends on the strength of the scapular muscles, and also depends on the mobility of the scapula, the coordination in the scapula, the mobility. If you have a limited scapular movement, you can't have a proper upper limb function. Just for example, now, as I'm going into flexion, adduction, and external rotation, the scapula is also elevating.
Yes.
So number one, what I usually do with my patient is everything. The patient can walk, can ambulate, especially patient with a weakness of trunk. You go straight to the scapular pattern, pelvic patterns. You can make combination to strengthen the trunk. We know how important trunk is in neurological patients. You have trunk weakness, even sitting up, or is it sitting down? Yeah, even to sit will be very, very difficult. So to talk of standing, some can stand, can sit, but you see their gait pattern poor. One of the reasons could be because of the trunk. Is it the upper trunk? Is it the lower trunk? Is it the rotation of the trunk? All those problems could be there. I think I did a workshop earlier. Was it earlier this year? Yes, around the Ramadan fasting for about 3 weeks. We did on balance. And the particular day we had a workshop on the trunk alone, which we discussed in detail how important it is. For example, the upper part of the trunk have to be sometimes immobile, have to be fixed to allow movement in the lower trunk. Sometimes the lower trunk have to be fixed for you to rotate. Sometimes for you to roll on the mats or in the floor, the upper trunk has to be fixed, has to be strong. So, this is the same thing also. The scapular region is weak, is immobile, or last coordination, could not glide on the trunk, then there will be a problem. So that's one of the things. We have the scapular pattern. So we have the scapular pattern. We have, if you go into flexion, abduction and external rotation, you have anterior elevation. If you go into the reverse order, extension, and what? Internal rotation and abduction, you have posterior depression of the scapula. So that's why we have this first diagonal D1 is anterior elevation going up and posterior depression going down. Then we have the D2. Let's just focus on the D1. We have anterior elevation and we have posterior depression. So what is the importance of this scapular pattern? I've already started talking about it. Trunk is very important. Shoulder problems, it will also help. Back pain will also help. Upper limb impairment, of course, because without those scapular function, the upper limb will not be able to function. Even you have all the better outcomes from the elbow, wrist, downwards. Just imagine you could see your patients when they come and you see them with the shoulder drop. What happened? You know that any other thing may not be able to.
Yes.
So those are that's also one of the patterns you can use to improve. Yes, when there is shoulder drop in stroke patients. So that's why most of patients, I just give them scapular patterns, femoral patterns, then plus other things that are primary to what because without this, there's going to be a problem. Even with ambulation, they could ambulate, but you see a lot of impairments with their gait. So yes, it's part of the flexion, adduction, external rotation, like I've mentioned. Then the posterior depression is just going into the reverse, is preparation for walking. The same thing with also anterior elevation too. It's also preparation for walking because it's a normal pattern for the walking. Yes. Also limb activities, mat exercises, changing position, and so on. So I think I will demonstrate so that I will not just be too bored with like a lot of theories. The usual subject. Maybe I should off this mic here, no? You want to use this one channel? Yes. So I should off this one. So now?
Yes, ma'am. Yes, ma'am. Yes.
Please mute your mic.
Like I've explained that it's my life. By using this. So just like okay? Yes. We have explained that there is one, like two. Want to focus on the one. Then I've said the one we have protection, and we have extension. The one is when we observe our normal working pattern. That's where we have, that's where we, so that's why this one was derived. Then the other one is the two. Usually supporting some other activities. You want to show something, you want to add something, you want to do other activities. That's where we have the normal working pattern is work. You want to go in, you start on the upper end, not just the lower, not just focusing on the lower end. Gate is a holistic even the upper end, because for how patients are not, they are fixing, they are not the upper end are not. Yes, the element of upper end is not there. So it's going to affect for so I've said that we have the work, this reflection. So, but I've said that we have flexion, it's going to flexion. We have rotation. This is external rotation, right? I know why it looks like that, but it's external. External rotation, shoulder. It's external. It looks like the hand is going inside, but the shoulder is going to different. This is the internal rotation. This is external rotation. So sometimes while we're making they get confused whether it's internal or external. So you can see it's not just going into flexion, but the hand is going, you can see the fingers, they are going into rotation, internal rotation, and it's going into abduction. And that's what I mentioned. One, we have flexion, abduction, going towards the abduction, and have external rotation. This external rotation. External. So going flexion. So you can see you don't just so you have this 3 dimension of movement. You have flexion, abduction, and external rotation. I've mentioned timing all those things for the maybe much later you can look at the others because
everything will have to be, it depends on your hip. But if you are going for the whole upper limb, then you have from the fingers up to the shoulder and back also. That means you want to rotate the lower trunk, even at sitting, the upper trunk cannot fit and allow you to move. Cannot fit. So many things. That's one of the things. All these body parts, those are the things, those are the individual things you look in management of the patient. We trace out the main impairments, then we deal with that, then we bring other things together. You miss some things, then you'll be doing so many things for weeks, for months. And you will not see, definitely, you will see maybe other things coming, but those specific things will not be there. We'll discuss about it to see that the patient have a problem with only initial problem. Because we ask the patient when he's coming back or coming and working again, or it's a resistance that problem, or it's terminal stance, or it's somewhere in the swing phase. That is the problem. Or we're focusing on it. We get what is required or what that patient is supposed to That's why. So we have three categories. We have agonistic techniques, we have antagonistic techniques, we have relaxation. However, you will see different classifications, different tests. All you need to do is just look into what they mean those techniques. That's for you to choose that technique for what you want. That's I think this is for more clients. You need to also be able to remember that we have to see that. So we can take the agonistic.
Okay, so I've talked about the anterior. So we'll now look at techniques. We'll now want to apply a technique of technique to anterior elevation of scapular pattern. So what technique do you want? Like I just demonstrated to us, we just apply pattern. But what technique? What is our goal? What do you want to do? We don't have any. So let's look at a technique now. Then we can go back and see how we can apply it to. Please, can you see it there? Is it?
Yes.
Because people are writing complaint here on the chat.
We cannot see anything. Your voice just came back now, but we
So
cannot
technique.
see.
Like I said, these three muscle contractions are some of the key for applying a good technique. We have concentric, we have eccentric, and we have the isometric contraction. So the interplay between these or among these contractions, that's what brings about the technique. So the choice depends on the patient. So I want to go back to this one of the techniques. So the goals is to facilitation of movement, to increase range of motion, to relieve pain if it's a technique of pain, to improve relaxation if it's a technique of relaxation, increase endurance if it's a technique that will increase endurance, then also strengthening if it's a technique that will improve strength. But like I said, these are the major muscle contractions that will help us in understanding these techniques. We have isometric contraction. We are all familiar with it. We have isotonic contraction. Under is we have eccentric and we have concentric muscle contraction. And I think that's where all the time there is a problem. So we have, let's look at the isometric. We know, yes, there is sustained contraction without changing length, without movement in the joint and so on, which is very easy. But where the problem is when there is eccentric or concentric contraction. And how do you put these two together? How do you give resistance for eccentric? How do you give resistance for concentric? How do we make sure we are isolating a certain group of muscles to apply this thing? Yes. So I want to demonstrate this also. Maybe we don't have to go to the couch. The concentric, eccentric. That will be my interest. I should off this one.
Eccentric is completely on one. And once you do treatments, you have to isolate whether it's eccentric or eccentric. You know, we say eccentric is when there is shortening. So eccentric when there is lengthening, concentric when there is shortening. Yes. But our focus in PNF is eccentric for biceps, concentric for biceps, for example. If you are applying agonistic technique, that is, you are only isolating agonist to be involved in movement. You don't want the antagonist to come in. For example, you only want biceps, you only want to exercise majorly bicep. You don't want triceps to come in. That's why it's called agonistic. You don't want to have any other muscle coming into play. Majorly, you come, but majorly you are. So you only want to have eccentric contraction of biceps and concentric contraction of biceps. Eccentric, concentric of only biceps. So I want to apply resistance to that. For example, now see flex, flex. This is obviously concentric contraction, right? Now we want to move into eccentric contraction of biceps. I will give resistance. I'll ask you to gradually allow me to move. It's approaching majorly biceps. That's why if you apply something like this, it's heavy. I know that it's really confusion because if there's confusion here, before if we go into techniques, there will be more confusion. That's why I dedicated this particular thing for us to get it. It's not about extension or flexion. While going into flexion, flex, I'm giving resistance to the movement, but I'm allowing you to go to, right? So I'm resisting concentric contraction of biceps. If I give resistance to this and give weight, then I'm improving the biceps. Then how do I give eccentric resistance to the contraction of biceps now is for him to resist my movement. Allow me to go through slowly, 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 This is eccentric contraction. Is gradually giving resistance. You are recruiting only majorly biceps, no triceps. But if I do this, flex, then extend. This is triceps. Just by changing, I told you, just change you are doing something entirely different. That's why we mentioned at the beginning, all this angry where you go, how you do the stance matters.
Young man, what are you doing? We cannot see the demonstration at all.
Yes.
Concentric contraction, biceps, resistance from
Yes. What we are going through concentric, when we are going through concentric, the resistance is from me. Right? Then coming back to eccentric, distance is from him. And going through this, I'm gradually pulling him, but he's allowing, it's not that he's holding. When he holds and I don't move, then we are going into isometry. But he holds and the movement is eccentric of biceps. But when he's coming and I just take my grip, this is triceps. Triceps. That will be concentric work of triceps. I've already turned into triceps. But if I do this slowly, biceps. Then slowly back, still biceps. Is it clear now? For all like this, let me just get some feedback. Whether they are continuing.
Any question?
Yes, so there is question. No?
It's not clear. If you didn't get this, if you go into the techniques, there's going to be a lot of problem. So let me demonstrate again. My target is now eccentric and concentric work of biceps. I'm not interested in triceps. If I involve tricep, it means the technique will be antagonistic. It means I've recruited agonist, I've recruited antagonist. So it's usually termed antagonistic. But if I remain with the agonist throughout my exercise, then the technique is agonistic. And I say there are various types. Under agonist, we have the unification, we have combination of agonists, we have the steps, we have many of them. Under antagonistic, we have also other techniques. So there will be differentiation of them. But overall, if you concentrate only on the agonist, you are applying an agonistic technique. If you apply agonist, then you switch an antagonist to go back to agonist. You are going into antagonist technique. So I want to remain with agonist. Eccentric, concentric contraction of bicep will be flex. I'm giving resistance. Though I'm gradually allowing you to go through. Let's go to the end. Let's go. This is concentric contraction of biceps. Then I want to go into eccentric contraction of biceps. I want to give resistance to eccentric contraction of biceps. Then you resist. Then you gradually, he's now going against my resistance, but gradually. Here, sorry, he's overcoming my resistance here, and I'm overcoming his resistance. I'm still within biceps now here. Eccentric, concentric, sorry, then eccentric, concentric, then eccentric. But when we go up concentrically, then I will now change my grip and say, oh yeah, come back. I'm recruiting triceps here now. Then I'll go into antagonistic technique. I've just demonstrated a technique here, which is called combination of isotope. You are combining eccentric concentric. That's the whole technique. But we'll take through step by step. So let me explain the technique. You can go for it.
Okay. Now looking at the agonistic technique, I said we have agonistic, we have antagonistic, we have realization techniques. The realization can be in various forms of combination of agonistic and antagonistic, but it's just another term to differentiate them from the goal of how they are being applied. That's why they are called realization. I've said it, you could see some text, you won't see this kind of classification. But what is important is you know how you're applying the muscle contraction. That is all. So we have the agonistic, we have rhythmic initiation, we have combination of isotonics, we have replication, we have techniques with stretch. Under antagonistic, we have dynamic reversal, we have stabilizing reversal, we have rhythmic stabilization. Realization techniques, we have hold relax and contract relax. So let's look at the first one, this one of the easiest. We have rhythmic initiation. Like I said, this is the background. Any technique you want to apply, you make sure you do rhythmic initiation. You make sure the patient is able to understand what you want to do. If he's not able to do rhythmic initiation, you have difficulty applying other techniques. So this is usually the foundation. So it has four stages or 4 steps. First of all, you do passive movements that we know, but the movement should be in the pattern, in the diagonal, in the joints that you want to apply. Then we have mentioned all those participation, all those hand grip, all those auditory stimulation, tactile stimulation, visual stimulation, all those proprioceptive stimulation. Then you have the second stage, which is assistive movement. Then we have the third stage is resistance. Then we have the last stage is pre-active. You ask the patient to do it. Like I told you, it's a stage. It's a technique that you want to make sure the patient is able to understand what you want to do. So the last stage, after everything, you ask the patient, okay, do it now, let's see. He's able to do it, you know that, yes, you can go on other techniques. He's not able to do it, you have to stay with that rhythmic initiation before you can move to other techniques. So what is the goal? What are the goals of rhythmic initiation? They are for learning and automation. And like I said, you want to make sure the patient have learned and automate what you want to do. To normalize rate and rhythm of movement, for improved sense of movement, regulation of muscle tone, to also help in relaxation and intermuscular coordination, of course. But this is not the best technique for coordination, not the best technique for strengthening, not the best technique for almost everything. It's just that it has some little things that is just helping, but it's not the best technique for all of them. So how do we apply this? There will be verbal command all through. So the first stage is passive. You just make the movement to the patient. You do it. Is it the upper limb? Is it the scapula? Is it the pelvis? You do it for the patient passively, for him to feel it. So, like I said, all the time, there are always instruction you give. You say, relax. You feel he's just following you, doing it. You tell him no. Let him get it first. Sometimes you want to move patient, they will just be doing it with you. But this time around, this stage, you want to make sure it's passive. You are just demonstrating for him. So he's trying to, you say, relax, please. Let me guide you. Let me move you. Just feel the movement. This is how I want you to move. Like I said at the beginning, there are verbal, there are anything you want to do, there are instructions for you to make sure the patient is doing what he's supposed to do. So then the second stage, you now say, okay, move with me. Okay, let's go together. Help me make the movement. So many instructions that you can give in Hausa, in any other language, Yoruba, English, any language you feel that this is the appropriate time that the patient can do what you want to do. So at this stage is assistive stage. You just be doing it together with him. You'll be directing him. And so then the third stage is resistive. You not give resistance, but we'll make sure this is agonistic technique. Resistance is only to the agonist muscle. Your agonist muscle is flexion. You cannot give resistance coming to extension. Your agonist is extension. You cannot give resistance going to flexion. Only going back to extension, that's when you can give resistance. Are we getting it? Sure. Then you say, work against my resistance. All those things, you give the instruction also. Then the last stage is, okay, demonstrate. Let me see whether you have learned this movement. Please, let's do it. Let's see. Please, all those things. Instruction, then you ask him to do it. Then he's able to do it. He's unable to do it, you go back. You do it over and over and over until he's able to learn. So I think now we have a technique now that we can apply. We have a pattern, we have a body part, we have a technique, we have a pattern. Now we have demonstrated a technique now. I think we can now go back to see. I think that's when it will make more sense now. So last time we just demonstrated part of pelvic pattern. Scapular pattern.
How now they are seeing it? I check if somebody making comment that you cannot see it.
Not clear.
It's not clear.
Yeah.
It's okay. Maybe the movement of hands. Very confusing. So you want to give. We have demonstrated anterior elevation. We have demonstrated anterior elevation and posterior depression, anterior elevation and posterior depression. But we said we are just making movement. We didn't have any target.
Someone said we didn't see it.
Is this now? Yes.
No, I think there are previous messages.
Previous message.
This anterior elevation, posterior depression. But like I said at the beginning, we say, okay, we have applied PNF, just did the pattern. But what technique? The technique is also what determines aim. For example, somebody with weakness, then we want to make sure before going into other techniques, this technique will help in improvements in muscle function and so on. So we now want to apply rhythmic initiation, which you say we have 3 stages: passive, active assisted, resisted or resistive, then reactive. But we say it's agonistic. So it means we have to know where we select. We select let's say our agonist is now anterior elevators of the scapula. Then we now have to make sure that we don't involve the antagonist, the posterior elevators. Thank you. And that's how we know how to place our hands and also the movement that will be involved. So the passive stage, we do it for the patient passively. This is how I want you to take the movements. Yes, to understand. See, I'm using my hand here to help in direction of movements, and here also to stabilize, because if you use one hand, you won't be able to do that. So I'm stabilizing and also giving direction of movements. So you can tell him, okay, wrong from here. So you can see this anterior elevation. Yes, it's purely passive. So I will now tell him the next is now help me. Let's do the movement. We go actively, but return passive. Because we don't want to involve the posterior depressors. So up and relax. I'll do it for you. I'll ask him to. The instruction is relax. So I will do it passively. So that's why I say all this.
You're doing something.
That's why there's a lot of you need to pay attention. The patient also needs to be paying attention. So up and relax. Up and relax. Up and relax. Up and relax. Up and turning up and relax. Active assisted. Then want to give resistance now. Up, and give resistance, relax. Up, give resistance, and relax. Up, and relax. Up, and relax. Up, and relax. Then show me the movement. So this last thing, if you're able to do it, you are good to do. You know that when you are going to do more complex things, you need to compare. But this simple thing, you're not able to do it. You go to other things, you don't get anything from initiation. So let's remove initiation. So this is remove initiation for anterior elevation. Now let's do posterior depression. So now we move back. Repeat the movements and do it passively. Although we may not differentiate now because it's not active, it's passive. So you move your shoulder back and then you passively this posterior depression. Anterior elevation, posterior depression. That's the I'll take the picture I showed of a lady on the clock. So you can see it. And you can see also just remember you can see my body position is also in diagonal. I didn't stay here or somewhere and say I want to be very difficult. So you see my feet also, my position. So passively. Now let's go. Push against my hand. Yes. And relax. Push and relax. I'm giving resistance. Sorry, I'm assisting now. Oh, I'm giving assistance. Push and relax. Push. I'm directing you. I'm not giving resistance. I'm assisting you. Push and relax. Push and relax. Push and relax. I'm assisting, giving direction, and also assisting with the direction of movement. Assist. Push and relax. To make sure we are not recruiting anterior elevators. We are not recruiting anterior elevation movement actively. So it's passively. Push and relax. Back and relax. So now the test is resistance. So push, relax. Push. You can see how my grip changes. Push, relax. Push, relax. So I'm taking him back. Push, push, and relax. Push, and relax. Push, and push, and relax. Push, and relax. So now show me this posterior progression. You see purely sequence. We try to eliminate antagonistic movements. So that's the technique. You want to document now, see, you apply a technique pattern. Couple of pattern. Initiation. One. That's why when I see PNF and I'll see okay, which pattern, which technique. These are the only two things I ask. You don't hear the answers from me. So you can see now this is the initiation into anterior elevation and into posterior depression. Yes, you can at least, but the name of the pattern, the name of the technique already has been there. So this is the pattern you use, which diagonal is a circular pattern, one into anterior elevation and initiation. You also do combination of acids. You also do stabilizing factor. You also do when next person comes, you know these are the things. Or you come out also be able to these are the things that you are documenting that you want to do, that you want to. We'll see on the documentation when we come to the section. We will see I hope I'll be able to cover this. We're going to talk and just advanced it. So yes, you apply the technique, this technique you apply. Then we will see also there are trial treatments. You try, and this one didn't work. You change the technique, you change this, you change the position, you change the resistance, you change many things. You make it try. Okay, this one didn't work. Okay, this one didn't work. Try you see on the document, then try one, try two, try three, which one work, what is the outcome of now, and then this one is the best. Then you continue. So this is I think we can take another technique. I want to go to theory. I don't want to mention it. I want to see. Oh, let's see technique. Which I already explained. We don't go to combination of isotonicity. That's what I explained during the
Okay, we have another technique which is also agonistic. We have combination of isotonics. That is exactly what I was explaining about biceps, eccentric, concentric. So you are combining the two eccentric. As simple as that. You are combining the two isotonics, sorry. You are going into eccentric, you are going into concentric. That's just the name. Combination of the two isotonics. That's the name. Combination of isotonics. You are combining eccentric, concentric. That's just the technique. But it has some rules guiding it. That's why I said, let's come back to the. That's why I said let's come back to the theories and now see. Then we'll go to the practical again. So, it uses dynamic work of muscles, concentric and eccentric, and as well sometimes static. The static is not too obvious. So, what are the goals? Improve active control of movement. This is where when you have problem with coordination, patient have problem with coordination, you are going to train for coordination. So it's improve. Strength is there, but not too much. Range of motion is not too much also. Strength and endurance could be there, but this is where you train coordination. Then, yes, I think other ones are just. So let's see the steps. You have dynamic concentric and eccentric combination of movement. Then you have changing the form of muscle contractions from. Okay, this particular technique is just trying to say that there is no change of grip. Then there could be stretch if you like. Eccentric is easier to perform after concentric. So you want to go into this eccentric, concentric. Try to do eccentric first, then you go into concentric and so on. That's what they're just trying to say. The steps. Therapists resist active movement of patients. Just like what I demonstrated. You try to move, I'm resisting. Then you reach to the end of the range of motion. I will ask you to hold. That is the static movement that you see. That's why you hear that it's static, but it's basically eccentric, concentric. But there's a static. Because at the end, you want the patient to hold that tension. The tension he came with for concentric, he shouldn't lose the tension. The same tension, he should go back. So you ask the patient, please hold. For him to now change into eccentric, then he go back. He goes through eccentric, you say hold. Then you come back into concentric. You hold, go into eccentric. It's basically the two isotonic, but you have a bit of isometric, but it's very minimal. It's just for the change of. So the patient is asked to slowly return to starting position, eccentric. So there is no relaxation. Like I said, you want to have that tension maintained. Even if it's losing tension, you now give instruction. Please don't lose tension. Let's go, let's go, let's go. That's why all the verbal instruction, auditory instruction are very, very important. So it's preparation for ADL, muscle training, and improvement of gait, and so on. So I think we can take the combination of isotonic now.
So now we want to give okay, slideshow. We now want to give well Mr. Initiation, which is a technique. Now we want to give combination. Like I said, which yes, especially coordination. Especially coordination. This is good for coordination. So we have continuous elimination. Yes. You say before anything. Eliminate association. Yes. In this case, you do the initiation, understanding system. This is the pattern. Let's assume that then we go into combination of S20. Yes. So now, instruction is now go against my resistance toward your eye. Yes. So hold. Now let me move you back gradually. Gradually. Up. Hold. Then back. Let me move you back gradually. He's going to resist. I'll move him back gradually. Yes. Similar to what I explained on bicep. Like I said, I was explaining, and I said it's already a technique I've explained to you, but just that I will come to you. When you come now, that's why I said if you have confusion with this bicep explanation, I think then relatively they're difficult. It's easier. You can see now, you have already explained it. Yes, you are correct. So up, hold. Now let me move you back gradually back. Hold, and up. Go against my resistance. Go against my hand resistance. Hold, and back gradually. Back, and you have lost tension. Hold. Up, and relax. Resistance to us. But in what direction? If we are only concentrating on agonists, elevators, and two elevation of circular pattern U1. We didn't change grip, we didn't apply for posterior elevation, no any other parts, only anterior elevation. You see, if the scapular pattern, pelvic patterns are clear, you know how to apply this technique. If you understand the pattern of the very easy for you. Because those that you get to see all one measure, all these things, then you are focusing on the pattern, you won't be focusing on the technique. But I think here is just one portion of the whole pattern. So that's why I decided to take that. Then we also look at it. So I think maybe we should start with demonstration. I think somebody should starting from the yes, and visual elevation and limit finish. We are starting in limit visualization. First of all, we start by passive. Just allow me to move. You can place your hand at the scapula, yes, to help you with the direction of the movement while you guide the movement so that you will not be moving in all directions. So yes, this is passive movement. After the passing of the elevation, then we go to active assistance. Yes. So we are assisting into active elevation. You go up, then relax, moving back. You also feel what that is involving contraction. Then you give the instruction that you relax. Together, relax. Yes. We go together. Then relax. Go together. Then relax. Then what? Then resistance. The resistance will be an elevation. Okay. This is now. Then grips here. Yes. You should allow him to. You are giving much resistance. I think people don't. You're doing a lot of spelling. So now the resistant, then you have the patient to do the cancel. Yes. You can come and try.
Passive evaluation.
Your hand, one of the hands should be on
Place
the scapula. Direct the movement, and here also to give directions, to support and also to give direction. This is happening. Make sure you are gliding the scapula, and the hand comes making sure it's directing it. One instruction you can give is you move your shoulder in the direction of your eye. Yeah, something like that. No, you do it passively first, then you give it assistance. You give assistance, and that's when you give resistance. So you are doing it passively. You are done with passive. Then you now say, okay, let's go up. You are doing it together. You should feel he's making efforts, and you are also augmenting the effort. That's the assistance. Then you give resistance. Then
So I'm not doing it.
it's like it's like maybe it's like you are in a hurry, and just
One
take
important thing, position of
yes,
the hand.
yes,
This hand, I feel like is
yes.
pressing on.
That's why I'm trying to give you direction. You place this is the scapula, you locate it. You see, I place my hand on the scapula, and I'm making sure it will be easy for you to move the scapula, because if you hold any other place, then you will just be moving the scapula in some other unnecessary direction. But you see, I'm holding it here, and here is to make sure it's heading to the anterior elevation.
Sometimes it looks easier when
Yes, that's what I'm saying. Please come on.
It's now the movement is good. You skip the assistance. Okay.
But one thing,
Free
you want to note also, when there are some neck pathology and so on, this is the time. Because I wasn't patient.
Okay.
So that's why we need to assess the patient holistically. When there are some kind of movement, you need to, especially neck. When there is neck problem, you do this movement, it's going to worsen the situation.
a patient with cervical implant.
No, you can't. Implant for is it?
Yeah, vertebral collapse. Cervical vertebral collapse. Cervical surgery. After fixation.
Yeah, I think this will be contraindicated. Yes, so we have to look for other things to do for the patient. I'm sure you're feeling the tension in your neck and the trapezius and
Yeah, especially trapezius. Superior.
so now the posterior, the pressure. So let me do this passively, and this is the movement. Passive movement. Passively. And assisted.
This is you have to tell the patient.
Yes. Now we begin the social. Yes. Yes. Now you tell him the social is like push against his hand, for example. Then you'll be doing that, but you know that it's no resistance. It's just for you to make sure that it's heading to this direction. Then you'll be assisting. Okay, let's go down, down and relax, down and relax, down and relax. down, down. Now resistance. Push, relax. Push, relax. Push, 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 push. Show me now. Now combination of these posterior section. Push, hold. Now let me move you back. Slowly, 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 slowly. Allow me to move you. Allow me to move you. The end to reach the end of range. Then now say hold. Because you want to maintain the same tension. And push back. Push, 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 push. And hold, hold. Then move back gradually. Then move back. Then allow me to reach. Allow me to. Yes. Hold. And push back. Push, 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 push. Hold. And back. Let's go, let's go, let's go. Allow me to push you. Allow me. And against my resistance. Push, 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 push. This combination. Let's see if we can try. Combination.
I don't know.
You don't need to. Let's say we are through with that. Yes. Yes. Or you can try for introduction. Let's see. Because this is a different technique now. It's like combination of isotonic. Anterior. Okay, so let's go. Now you are going to resist this. Yes, look, as he's going up, you are resisting, but allowing, but now you are now resisting. He's going to go against your resistance while coming back. That while going to eccentric.
When I'm resisting, that means when I'm resisting anterior elevation,
you are going into concentric. Then he's now resisting he's now going against your resistance. Then you are going into eccentric. Yes. So your grip will be all through here, then up. Now I'm going against his he's going against my resistance. Now then I'm now pulling. He's now allowing me gradually. Hold. Don't lose tension. Then move gradually back. Yes. Against now. Yes. Now against your resistance. You go back against his resistance. That's combination. Maybe we can try. You have to try. I don't know how many times I've tried position. So let's go. Okay, so let's go off. Your resistance is too much. Allow movement to go. Just reinforce. You can use one hand, but it's just to give reinforcement and also safety. Also give direction. You can use one hand. So let's go off. Off. Yes. Excellent. Hold. Now you take it back. Yes. Gradually. That's the eccentric. Yes. Off. Concentric. Off. Hold. So allow me to take it back gradually. That's combination. You can apply this for the body. Apply the rolling pattern. Learn the pattern now. You know already what problem is. The weakness is this and that is coordination. Let's start.
Please stabilize the next step.
Yes.
Like this. Then one hand here.
So are you going to enter elevation or pursue depression?
Anterior first. Then
Sisters. Nothing to relax. You make sure he's not making contraction. You are the one that just passively returning. Relax.
you actively go
Go up and relax. Then you give resistance. Yes.
Okay.
Up and
You bring it
relax.
down.
Relax. No, you tell him to relax.
Relax.
You just take it back. Up, relax.
Then
Yes. Up, relax.
If you put your hand elongate close to the neck, then the patient will not have freedom of movement much.
Okay. Usually just within the scapula and
Like
shoulder.
here.
yes.
Yeah.
Then
Yes, you can try the posture, then we can try the combination of bicycles.
bring it down. Passively.
Yeah.
Okay. Then we go.
Sister.
Yes.
Resistance.
The bed is low.
Then combination of
That's good.
combination of
It's the combination.
which is anterior elevation or posterior
But the combination.
Yes.
Okay.
Anterior elevation or posterior.
That's the posterior.
So instructions, let him push against your resistance. You are resisting.
So he's bringing it down.
Yes, he's pushing you. That means he's going there concentrically. Then you now
As his
push. Yes, now give resistance. Yes, push against your resistance. So yes, hold. Then you push. Then you now push. Then you be resisting.
Okay. Then you push.
Yes. So let's try.
So now I'll push.
Yeah,
Push. Push.
You allow movement to.
Yes.
Go.
Then now he be resisting.
Then you push.
Then
You
I'll
be
push.
resisting.
Yeah,
Yeah,
push.
pushing.
Yeah.
You get it.
Yeah.
Now
Yes.
you want to
It's like
right.
then we have to allow me to go, then allow me, then
Yeah.
I will allow you. Allow me, then allow you. Then you are eccentrically, concentrically. This is the same thing that we also have with other treatment. I think it's not just PNF. About our managing patients, especially medical patients, we know we only concentrate on egoist. Patient comes and we check bicep strength. I would say the bicep is weak. We just give weight. It's just going to concentric. We don't focus on how he's turning the foot down, the flexion, the extension, the going into flexion, or it's going into eccentric. For example, we ask patients to just sit. Yes, we just say take weight.
Okay.
Now you have idea that we are only managing the quadriceps, the concentric work of quadriceps. But we say hold and take it back slowly. Take it slowly. You see the patient walking.
Yeah.
And if you ask patient to sit down, Oga, Baba, sit down.
The hamstring. You teach him.
It's not the hamstring. It's not the hamstring. We say hamstring. Okay, Baba, come back. We give weight. You just be fine. You just give weight. You just be throwing the weight also. Sit down. It's collapsing again. But hamstring is fine.
No,
It's
concentric work of quadriceps.
People of quadriceps is this.
Yes.
It's going to collapse into the chair.
Yes.
Same thing with rising up also. If the eccentric work of the hamstring is also
Not there.
You cannot do it. And you think, is the quadricep is weak. Well, let's go. We give weight 5. Even if there is 10, you get 20 in the strength. But you will not see the results. That's because of this concentric contractors. Then we are always missing out on the concentric. We always focus on it.
Means if we are doing quadricep exercise with weight, then we ask the patient to to flex slowly, so that we get.
Yes, if your target is eccentric, if it's both of them, eccentric, concentric.
Yeah.
If it's eccentric, you do that. If it's concentric, depends on where you find the weakness. The same thing you ask patient to squat also. We say take the 1 bar squat. Patient is not doing this. He's not jumping. He's just doing the concentric work of the quadriceps and concentric work of the hamstring. He's just not doing this.
Taking it slowly.
If you ask him to come up, that's when you see real slow. Even for normal individuals, try this eccentric work and see. That's all the result that's coming up when you do puncture.
Yes.
That's when it is the eccentric muscle. There is something training the eccentric. That's why you see the next day. Yeah, there is the lactic acid that here all this, but it's the eccentric work that will be giving you problem. So not just PNF, this is applicable in management everywhere. I usually teach my auto plants. Sorry to the auto people that yes, also, and I'll tell them that in neuro we go specific to you guys. I will tell them you guys also are just our strength now. It's strong, but we try to see coordination, find movement there, being taken care of. That's how it is. Most of it. So the same thing with gates, the same thing with many things. Even with trunk activity, is it the strength or is the coordination of the trunk that is missing? When you check the test from some instruments, trunk, you see strength and you see also coordination. So that's why also the students also take care of coordination. Thank you.
You have to be just like what you said. You have to be intentional of what you want to do. You have to be intentional. When I did the PNF course, I was like, what did I even learn? I was just very confused. But over the years, I was practicing on patients day in, day out. I was always going back, referring to the books, doing it, correcting myself. And although we did it in 2 parts, we have a part, then after about a month, you go and practice. Then you come back and do the remaining half. Like I told you, it's 1 and 2. So you do 1, you go back and you have to practice. Then you come back and do it. So it's not that you do everything and just go. So you come back with the instructor also, you'll be observing you, he'll give you case studies, he'll give you a lot of patients, he'll be observing, he'll be correcting you, all those things. Then that's when everything will now perfect. So, but it's gradual. Rome was not built in 1 day. So it's just gradual, everything. So we have the D2 of scapular pattern, which we have posterior elevation and anterior depression. We have anterior elevation and posterior depression for D1. Now we have posterior elevation and anterior depression. for the two. That's why I don't want to bring all this additional. Well, like I said, it's a lot of confusion. So we have D1, which I've talked about, posterior, anterior elevation and posterior depression. This is what we did. D1. We have D2, posterior elevation, anterior depression. Just like we have for the upper limb, for example, we have.
So that means the diagonal of that
Yes. We have diagonal 1. This is diagonal 1, anterior elevation, posterior depression. Go. Then we have diagonal 2. Anterior depression.
Yes.
Posterior elevation. When you just repeat the upper limb pattern, you understand the pattern. Yes, this is anterior. This is, you can see, is going into depression. Anterior depression, posterior elevation. That is the 2 for the scapular pattern. I'm just breaking down bits. I don't want to go. That's why I said I don't want to go to the upper limb. We'll talk about the shoulder. We'll talk about the elbow. We'll talk about forearm. We'll talk about wrist. We'll talk about fingers.
So we understand.
That's why I just limit to scapula so that we can understand the diagonals. We understand the techniques. I think even if you begin to read by yourself, you know that okay, this is the pattern, this is technique. Any other place you can apply. But if you begin to bring all those complex patterns, then we'll now bring technique. At the end, we may just end up with nothing. That's why we just take it small. We just understand. I think the techniques are very clear now. It's just now additional technique, additional pattern now it's trying to bring confusion now. So we have D1, which I said is almost replicating our normal gait pattern. That's D1, sorry. We are working. That's, if you just want to remember D1, just remember how it works. So you cannot exacerbate your hands and your arm swing. Just how you walk. That's the 1. Then the other one. That's the 2. That's what I said. Gait pattern for D1. D2 is for many other activities we do. I've mentioned the sport, I've mentioned many activities. You want to throw something, you want to, all those things, you'll see is the 2. So we have.
Mostly PNF is not only for patient.
Yes, even the sport activities, yes, and for different specialization, not just even for neuro, orthopedics, pediatrics, all those things is there. In fact, there are even specializations, even courses for pediatric neuro, for orthopedic neuro, for sports, for different kind of PNF for them. But basically, we manage patients. So maybe let's see the 2 of the scapula before we go so that we can ponder on the additional confusion. I remember the last presentation, I put all the upper limb and I believe and I saw how people were confused. That's why this year I said, let me just let's just take this. So now it's D2. You can now see my position as same because I'm this diagonal. First time was 1. I'm this diagonal. Now is this diagonal. You can see my position now. That's why I mentioned the position. So now is anterior depression, posterior elevation. Look something like this. Posterior elevation. That's the one. You hear one, and it's in 2 directions. You have one. You have the one in the other direction, the other direction, the 2 direction, between the other direction. So we have 2 into posterior elevation. The 2 into posterior depression.
the two into posterior elevation, the two into anterior elevation. Now the duration will make you know where is the posterior. So let's start with the anterior, sorry, with the posterior elevation. Now, let me pass it. Up, down, passively. And I get it to sorry, posterior elevation. Sorry, posterior elevation. Why is it not anterior elevation? Anterior elevation is in D1. This is anterior elevation. Now is anterior. This is not posterior elevation. Now, the reference is coming into depression and anterior. Now it's going into elevation posterior. So our target is now posterior elevation. That's the agonist target. So now let me move up and relax. So let's go up and relax. Let me take you back. Up and relax. Up and relax. Up and up and relax. Up and relax. Now resistance. Let's go up, relax. Up, relax. Up, relax. Up, and up. And now let's see. Posterior elevation. Now let's see anterior depression. Now go down. If it's passive, you can't differentiate whether it's agonist or antagonist. So just move. This is the movement I want you to do. I want you to just take your elbow down. You tell yourself you want to take your elbow down. Yes. Then let me assist you now. Assist me with movement. Down and relax. 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 Down. Now let's give resistance. Down and relax. Down. Use two hands. Some complication. One. Push. Push my hand. This is depression. Then let's try the combination of isotones. You see, this is not a patient. That's why it's a very easy. That's where people before. This is not a patient. It's able to he knows what to enjoy the patient. And this is a very serious mentality. So he knows how to enjoy the patient. We have done this like 3 times with him. I think this is the 10th workshop. So we are doing something. So this is a very simple for me to do that. But if it's a patient, to be a toggle. So up and hold. Then let me move you back slowly. Up and hold. Then move back slowly. Up. And hold. Let me take you back slowly. Up. Now posterior depression. Down. Hold. And let me take you back. Slowly. Hold. And down. Push down. Hold, and let me take you back. Slowly, and back.
So
So if the patient understands,
they
you
don't
don't
have to
have
hold.
to hold.
You
You
just
just
go
go
in
in
to and
to and
fro.
fro.
It's
It's
not that
not
you
that
don't
you
want
don't
the
want the
patient to
patient
lose
to lose
tension.
tension.
If
When
any
patient
conflict,
conflicts,
you just
you
need
have
to
to
move.
move.
Then
Then
you
you
have
have
time
time
to
to
understand and
start
go
to
back.
go back.
Then
Then
come back.
come back.
If the
If the
patient
patient
understands that
understands
you
that
can be
you
able
can be
to
able to
go
go
eccentrically,
eccentrically,
concentrically, moving up and down. Maybe you
maybe
can
you
go
can
and
go
try.
and try.
Posterior
Posterior
elevation,
elevation to
anterior.
your
Eh?
eh?
And see. You are
That's
sick.
it.
Sorry. Bro, so sorry about it. You can try. Right. Let's try anyone on the now it's posterior elevation. The one
One
of
of now
the posterior combination of the posterior elevation. Posterior elevation. Okay,
Okay,
you are okay.
okay,
What's
you
your
also go for the
initiation?
initiation.
Okay,
All
all
very
very
nice.
nice.
Okay,
Okay, talk.
take it.
Okay,
Let's go
to
to
push my
push
hand
my
and
hand
take the shoulder
shoulder
off.
off.
Which one?
Which one?
This one.
This one.
Posterior.
Posterior elevation.
I was snapping. So, just me too. Yeah. Look at this. That's a combination of acetone for the posterior elevation, then for the posterior arm and anterior depression.
Okay. So push my hand, push, hold. Allow me to take it back slowly. Push again. Push. So allow me to take it back again. For the anterior depression. Usually, they will suggest that your hand, both of them, should be on the same place. Unlike what you did here. Yes. When you have it here, both of them, this is the direction of the hand. Yes. And if
Yes.
posterior elevation of shoulder.
That's why initially when he separated his hand, I asked, which direction? Yes.
Anyone question that? Those online. Anyone with question, comment, or comment, or contribution? You can also write it on the chat box. No complaint. Let's come back. I knew that.
Okay, thank you. Thank you very much for the question. Yes, the first question is on incorporation of traction and approximation. Yes, you apply traction and approximation, like I've mentioned at the beginning, is when you need more contraction from the model. When you feel the patient is not giving much contraction, you can give approximation or you can give the traction. And also, what grade of muscle strength will you apply for when you apply for PNF? Even at level of 0, you can apply for PNF because that's where you have the rhythmic initiation. Yes, it's passive. And also to some level, if there is strength, you can apply the active assisted stage. So it means only you can only stop at passive and active stage. And I've also mentioned about irradiation. There's also irradiation, which you can stimulate a body part that is weak from another body part that is strong. But this is very advanced.
I used to see this.
Yes, I think I did with you sometimes. Well, last time yes, you can do that. So I think it depends. Yes, you can do that. I hope I've responded to the so maybe we can go on break.
I've been seeing similar
No, no.
Good afternoon. We are all welcome back to the second session of today's presentation. We have looked into various patterns, specifically scapular pattern, the 1 and the 2. We have looked into 2 techniques under the scapular patterns, the 1 and the 2. So we can now look into pelvic pattern. Yes, that's the lower limb pattern. We can look in the pelvic pattern, the lower limb pattern, and also look at the techniques we have practiced. We can look at the initial rhythmic initiation. We can look at the combination of isotonic. We can add another technique in agonist or antagonist. We can add that. Then we can also then see where we can go from there. Then we can look at the documentation, which I promised to look at. Okay. So we can see here, this is a pictorial presentation of what we had. We will see anterior elevation. You can see anterior elevation of the scapula. You will see posterior depression. Facilitation of posterior depression, probably giving resistance. You could see here is the instructor is giving resistance to posterior depression. You could see it's giving resistance to anterior elevation. I think it's clear. Oh, there. Then we could see here giving resistance to posterior elevation. We could see also here resistance to anterior depression or facilitating anterior depression. This is this particular person is the first person that became instructor in Poland. His name is Alexandra Isak. So sorry, is it Lizak? Not Isak is a footballer. I just realized I mentioned some footballer from near Newcastle. So I think it's Alexandra is it Lizak or something? Yes, but this Alexandra also his name. So I can't remember the exact name. Sorry. So this is anterior depression, and this is posterior elevation. This is anterior depression, resistance for anterior depression. So you can, this is probably he's giving facilitation to the anterior depression because he's assisting with the movement. If it's resistance, the hand will be at the elbow to give resistance for going down. So we can look at also pelvic pattern, which is part of the lower limb pattern. The same thing, just like the scapula. We have anterior for D1, we have anterior elevation, posterior depression. D2, we have posterior elevation, anterior depression. Same thing, just like for the scapula. And applying also technique is also the same thing. So we can look into that. We can look at it.
So now this is now pelvic pattern, and just like the upper limb, we have the lower limb pattern, which is how we predict the lower limb pattern. Upper limb we have flexion, both the adduction and external rotation. The same thing, flexion, adduction, also external rotation. And this is while we are having this, we also have anterior elevation. We have posterior depression. Posterior elevation. So posterior depression. Same thing, just like the upper limb. So we have posterior elevation. Anterior elevation, posterior depression. posterior elevation, posterior depression, anterior elevation, posterior depression, just like that. Then two, posterior elevation, anterior depression, posterior elevation, anterior depression, posterior elevation, anterior depression, just like that. So it depends on now which technique what is our reason for the decision. Let's start with unique initiation. Taking the unique initiation to agonist anterior elevation. So we are going to have the first stage, which is passive, passively. Then let me assist you go up and relax. Up and relax. Up and relax. Up, relax. Up, relax. Up, relax. Up, relax. Then let's go up against my resistor and relax. Up, relax. Up, relax. Up, relax. Up, up. Now do it. Ready initiation for anterior elevation. Oh, yes, sir. Passive. Let's go together. Fix here. And only the problems. Yeah. Then move. Resistance. Resistance. Now I want to relax. Up. Relax. Then shows the movement. I was so So this is elevation, dynamic initiation. So the same thing, posterior depression. Where you can see my position. So now passive. And assistant, push my hand and say, okay, it's assistant, sorry. Let me help you. You go down and relax. Down and down, down and down and relax. Down and relax. Now sit on my hand. Push. Yes. Relax. Push. 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 Now. So that's the last stage. Positional illustration. This is one. So let's look at the two. I think now it's not easier to go to one. Not unlike from the beginning. So now we can go for okay. It's gradual. I know after this today, you will try to remember tomorrow it will be difficult, but when you advance, no, you can do anyone. Choose anyone. Okay. Posterior elevation. So let's. I think for you, like we say, it's facilitation. You make things easier. You hold the knee, just like we did for the elbow. You easily direct movement, and here you also support. Yes. And the assistant. Also assist. We push it back, relax. Push it back, relax. Push it back, relax. Push it back, relax. Then the resisted. Relax. relax. Let me. So you posterior elevation, posterior elevation. So now we go to posterior elevation. Go up. Sorry, we are going into elevation, posterior elevation. Okay. Now let me assist you. Up and relax. Up. See, I'm taking it back. This side. Up. This side is giving the push, and this one is making sure it doesn't go into other direction and doesn't go beyond. Then while returning, this is giving the direction and the support. Then this is returning the patient. I think it's much easier. And relax. Up and relax. Up and up and relax. Now push up. Push. 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 Elevation. Now push, hold. Then let me move you back slowly. Let's go back slowly. Hold and push against my. Yes. Hold. Let me move you back slowly. Slowly. Okay. Hold and push back. Yes. Hold. Now let me move you back slowly. Move back slowly. Hold and push back. But let me just take us a bit ahead also before coming into combination. You can combine pelvic and scapular at the same time. But I said when the patient understands, this for also coordination in the trunk, especially for the combination of isotones. So the combination will be, how do you want to combine it? Are you all going in the same direction of the diagonal? Same diagonal, same direction, same diagonal, different direction. For example, this will be going in opposite. So you're going the same. Let me explain what I mean. Okay. For example, you go into anterior elevation. Let's see. Go into anterior elevation. And posterior elevation. Okay. Push. Yes. And let me move you back slowly. Hold, and hold. Let's go back slowly. Hold, and let's go. Hold. Let's go back slowly. And let's go. Hold. Let's go back slowly. Combination of isotonic of combined attacks, pelvic and scapular arch. One, all of them. All of them. They are the same diagonal, but they are going in different directions. This one is going into anterior elevation. This is going to different direction. This is going to anterior elevation. This is going to posterior elevation. There are a lot of things you can do. It's just one thing. Just a lot of things you can do. So this is just a combination you can do. Pelvic and scapular. You can see the applied combination. So you can also reverse it. We need anti-elevation for posterior deflection. So you can reverse anti-elevation for pelvis and posterior deflection. So this point is high. Yes, it's almost like reversing. It's the same. We are going in opposite direction for the same diagonals. The same diagonal. Let's keep it. let's
It
let's
will be easy for the same direction, the same diagonal. Yeah. Because elevation and elevation.
Let's keep this one. It's just that I have done the pelvic pattern, so I said let me just add this one. We'll come to the combination of patterns. I will see how many we'll be able to look at. So now we will now look at go back to upper limb pattern. Okay. Just look at one component of this pelvic pattern. So let's see shoulder. Therefore, let's see whether we will go beyond shoulder. But let's see shoulder. Yeah.
Okay. So now let's see the upper limb pattern. Even though the scapular pattern is also an upper limb pattern, but it's just a component of the upper limb pattern. Yes. So now I'm just talking about shoulder now. So in shoulder, we have D1, just like in the scapula too, we have D1, we have D2. And we have D1 into flexion. We have D1 into extension. We have D1 into flexion. We have D1 into flexion, and we have D1 into extension. D1 into flexion is we have the shoulder going into flexion, adduction, and external rotation. Then the reverse going into extension, abduction, and internal rotation. That is it. Then we have D2 going into flexion, abduction, and external rotation. Then we have extension, adduction, and internal rotation. So what is the importance of the D1? Even the upper limb is, especially D1 is for gait, preparation for gait for so many ADLs because it's the normal pattern of walking. So this is the picture we can see here is coming from extension to flexion. It ends where the movement ends is the name you give it to it. If you start from flexion and end, is in extension. So that's where you call it extension, abduction, and extension, abduction, and internal rotation. If you are starting from another direction and you are going to stop at flexion, adduction, and external rotation, so that's the name of the pattern. So you can see the instructor here is stopping at flexion, adduction, and external rotation. So that's the name of the pattern. We could see here on the next slide, he's going back to extension, abduction, and internal rotation. We can see that. So I'm only concerned about the shoulder now. I'm not putting another trouble. So we can see the
is flexion, abduction, because we are abducting and coming towards the trend. We look at it as external rotation, not defined as abduction, external. Then extension, internal rotation, abduction. Away from the body. But depends on how you what's movement you are interested. I think for you to have the full range, you have to ask the patient to come to the edge of the bed. Have flexion, abduction, extension, abduction, internal rotation. I'm just concerned about the shoulder. As we just did for the scapula, now we are only concerned about shoulder. Because if you are not to talk about it, you can see on the picture there, you can see the patient grabbing his hands while they are at this stage. When they are coming back, the hands will extend. Coming back, you make a fist up, then goes to the extension. So that's the normal time of measure. You have to watch from all to the end. Then also going back. That's the moment. Start with then how flexion, fingers, wrist. It depends also. There's a technique that you have elbow flexion or elbow extension. Depends on what you do. The same thing for the lower. If you have the flexion, you have the extension. You can see different variations of it. It depends on your patient where you have this. So we have our techniques. Two still carrying out. So we don't just do it also depends. Your grip, your change of grip, it depends also on the technique. Technique you're applying, you see it's three-dimensional movements. You see the rotation, you see the abduction coming, you see the internal rotation here, the external rotation, you see the flexion, and you see also the abduction. So, it's the unique initiation. Okay? Just do the movements. This is the movement I want you to learn. Okay. Now, just let's go together. Let's do the movement with me. Yes, and relax. Up and relax. Up and relax. Up. You can see, I'm in diagonal position. Up and relax. Up and relax. Now you can give resistance. Up and relax. Up and relax. Up and up and now should be initiation for the upper impact, but really focusing. So now let's go up. Go against my resistance. Up, up, up. Now let's move you back slowly. Let's go, let's go, let's go, let's go. And up. Go back. Go to the resist. Slowly. You resist. And up. Okay, and there's another technique called replication, which is also a mechanistic technique. Have the replication mechanistic technique. So this technique is patient with perceptual problem, patient with finding position problem. So you want to, you just like the initiation for them, is for them to learn the direction of movement. But this one is for them to feel movement, the end range, the particular position that joint is supposed to be. So that's where you have the replication. Let me take
So you could see on the picture, the patient made a fist. Is the picture? Yes. So, but I've said we are not talking about fingers, elbow, wrists, and we just focus on the shoulder. That's just what we did now. So let's look at replication. Yeah. I don't have it here, but we can just explain. No problem. So in this replication, it's just to hold the position of a certain it's just to hold a certain joint position for a certain period of time for 15-30 seconds. Then you just ask the patient to relax and ask the patient to locate that joint position again. It's a very simple, it's one of the simplest, I think, technique. I checked, I didn't have it here. So let me just explain. Let me just demonstrate it.
Patients having problem with finding the joint position. So let's have the pelvic scapula. So ask patient to go into anterior elevation. So patient to hold that position. Hold. And relax. Can you find that joint position? As you up into anterior elevation. Yes. So you hold for some seconds. And ask patient to relax. Relax. Go back to it. Can you go back to that position? So that's the replication. That to replicate what you have done. So people finding problems with profession, especially practice, acknowledge, learn those
Yes, that's what we define joint position. So we now replicate the joint position instantly for them. But as you are applying resistance, you are also stimulating the proprioceptors because they are finding joints, they are found also in the spine, other muscles. So they are stimulating. So that's simple answer. Then how do you do at least even if it's demonstration for elbow? Of course, no, because you have attended this this is the third or fourth time I think. The old way we had one there. This is the second one I know. I'm also holding seminar with you. So that's why you want to go somewhere. You understand? That's why I want to drag them. That's why I want to drag them. Because you have already attended me. So that's why. I'm looking at also something that we look at.
This scapula and shoulder. Truly, sir, what I'm looking at most of my question where I have problems.
The elbow and wrist.
Yes, elbow and wrist. Where you good work,
but your scapula, the shoulder needs to be okay before you have the elbow.
Yes, I think that's scapula. I saw that scapula and elbow, scapula and arm, they are big muscles. To learn the movement, to bring the movement, at times it's not that difficult for the patient to learn how to move his shoulder and scapula body. Supination, coordination, and find motor activities. That's where you take time before the patient. If I add PNL to that, likely I will start to get something.
Let's look at that technique. Okay. Let's look at combination. We have done combination of scapula and pelvic. I have demonstrated how you can combine the scapula. So you can combine the two upper limbs also with some activities. You can combine the two lower limbs. You can combine the upper limb, the neck, back, combine the pelvis, pelvic pattern, lower limb also. So this is how you name the combination. You have bilateral symmetrical, just like what I was trying to explain the other time. Brian was trying to bring and said, let's not bring this. So when you have bilateral symmetrical is when you have same diagonal, same direction. You get it. This is diagonal D1. Oh, this is D1. Flexion extension. Oh, and this is D1 also for the second arm.
Yes.
D1 flexion extension. So when they go,
okay,
same diagonal and the same direction.
Yes.
So that means is
bilateral symmetrical.
Bilateral symmetrical. You understand? Bilateral symmetrical. The same diagonal, D1, the same diagonal D1. They are going at the same time, same direction. Symmetrical. Okay?
Yes.
Then you have bilateral symmetrical. They are the same diagonal, but this time around, this one is going up, this one is going down. Okay. So this is going they are on the same diagonal. Flexion, extension, one. Flexion extension is one. And this one is going up.
This one is going down.
So it's going down. So that's why it's different. That's what it is. They are going in different directions, but they are in the same direction. If you look at them, they look confusing, but they are on the same diagonal. It's not like this one is going to flexion, this one is going to extension. So they are the simple level. Then we have bilateral asymmetrical. This one is going into the one, the other one is going into the two.
Oh, same direction.
Like this.
Yes.
Like this.
Yes. As if you catch a ball, you want to.
They are going in the same direction.
But
they are
different
not- they are
diagonal.
not in the same direction.
Yes. Bilateral, asymmetrical. Different.
You understand? You get it.
But different diagonal, but the same direction. This is going into anterior, and this is going into stereo.
This is going into the one.
Yes, this is going into.
You get it now. No, this is the one. This is the two.
Yes.
But they are in the same direction. When you want to do something, you want to do something, you want to throw.
Teaching golf.
You are in a golf, like basketball and all those things. You are in the same. This one is in the two. This one is in the one. But they are going in the same direction.
Different diagonal.
Different levels. So that's why they are not symmetrical. So that's why they bilateral asymmetrical. Then the last of different is bilateral asymmetrical.
Different diagonal, different.
Reciprocal.
Reciprocal.
This is
Reciprocal. Different diagonal, different direction.
This is first one. Then this is the bilateral asymmetrical. You can see it. Then we have bilateral asymmetrical. Okay, you want to see it?
Yeah.
Take it. So those are the you see this one are the same diagonal.
Yes. Posterior.
You see the two. This is asymmetrical. This is reciprocal.
Yes.
This is asymmetrical. Asymmetrical.
Balance and strong.
So, okay, let's move on to lower limb. Or as you said, we should add the
Elbow. This form.
let's take lower limb. Let's take
Elbow and
So lower limb.
The same thing. The one also the two. The one is where we have anterior elevation, posterior elevation. We have in the two posterior elevation, anterior elevation. So in the one, we have
We have hip flexion.
Flexion, abduction, and external rotation. How do we know? This is let's make reference to this way. No, just like so you can do it in the sideline, but let's try it easier. Flexion. Flexion. Abduction. Yes, you have flexion, abduction, then external rotation. So this what he did was with extension of knee. Yes, you can also try with flexion. So this is external rotation. This internal rotation, and this is flexion of the knee. And this is also abduction. So we have internal rotation, abduction, and extension. We have flexion, abduction, and external rotation. When you do this, it's external rotation. When you do this, it's internal rotation. External rotation, abduction, and flexion. Internal rotation, abduction, and extension. So maybe you come close to the edge of the couch. Yes. So extension, going into flexion, abduction, and external rotation, internal rotation, flexion, extension, sorry, and abduction. So this is the one. Just like what I got, just that's the one. So let's apply it. Let's try a combination of flexion into flexion direction. So let me, okay, go against my resistance. Yes, hold, and let me gradually move it back, down, and up, up, up. So that you 185 from up, down, push, down. Okay. Now you resist. Now you get it. You resist. Push and resist. Push. Get it. So I only concentrated on the house. The other one was
Definitely, yeah. You see, you are right. Well, when I train, you go to their office, you see IPLFs and you see that overs, you see you see all these things. If you enter some office, all those certificates, you know you are going to be. Of course, that's what you have. We talk about going to courses, you must spend a lot to do that. So that's what you see on the office, all the certificates. So is going to combine. You know that you're expecting that you are going to get better. We know all those things. Because there are a wide variety of expertise, and that expertise and variety of treatment approaches and all those things. So also be it's good. It's good. Okay, so that's one for upper limb, one for lower limb and down. Upper scapular pattern, 1 to 2. Very pattern, also they will use some combination of things you can do and give resistance not to show doing this. But all this is, like I said, very harmful combination. So you can make all this combination. Okay.
You can circulate it. I will also share it on the slide. Not to forget. So before we take on any other thing, let's look at the documentation also. We know how documentation is very, very important. This is a hard copy. I have only one copy here with me. So I'll also display on the PowerPoint. So this was developed by Maggie Notes, like I've mentioned. It's an assessment and treatment card. So it's not just for documentation of treatment, it's also for assessment. And we know how important it is during assessments for accuracy, for clarity. If you want to come back next time, you're able to replicate what you did. For clarity also, next person wants to come and he wants to look at, he wanted to replicate, wanted to see what you have done. He will now be able to document what. So accountability also, accountable for what you have done for improved outcomes, promoting proper record, optimizing care. For training, you have students, you have interns with you, you also use it for training. So the first page we'll see there is just socio-demographic data, name of the physiotherapist, name of the patient, date of birth, profession, hobby, diagnosis, and so on. I've mentioned at the beginning that all these things are very, very important because you want to know what the patient is into, his profession, what is his hobby, what does he want to learn further, what are those impairments that are impinging on his activities. So what are the activity limitations? What are the things that the patient is just mentioning that he could not be able to do? You can use objective methods to assess this limitation, but this is just to document subjectively that he cannot do this. These are the things that he's having problem with. Then you can see the next page is the problem in the ADL. You should describe at day 1 what happened, at day 2 what happened, at day 3, 4th day, and so on. What are the problems that you encounter while it's carrying the ADL? Then the tests, the various tests you have applied for ADL. I'll just keep through this thing. There is a place I want us to discuss. What is the cause of the activity of daily living? You now generate some hypotheses. What are those things that will lead to those impairment? Is it Moses strength? Is it range of motion limitation due to stiffness probably? Is it coordination problem? You have done finger to nose test, you find out that it's having problem, or heel to shin test and other things. You find out that it's pain. What technique will you use to manage the pain? And so many other problems, you can assess. Then, like I said, you have treatments. What do you observe? According to them, you are supposed to even assess patients before and after, even every day. You assess before, you give treatment now. Before the session. 1 hour, 2 hours. You also assess whether that's your treatment have given, even if it's a little improvement. Yes. Yes, it's possible to see. Yes, when we're having the course, we have patients, we assess before and after. I could see some little things, even though there is issue of retention. You could do something for 1 year. You leave the patient to go home. You come back with a relapse, not really a relapse, but he has not retained what you have taught him because probably he has not been doing it or some other things. Then you also see, this is assessment of trunk. You see asymmetry. You can use also weighing scale, 2-weighing scale for patient to stand. You know where the weakness comes from when it tilts, when the weight is on a certain side. And this is gates, which I said will be discussed in the next presentation. We have initial contact. We have the mid stance. We have terminal stance. We have pre-swing and various sections of the gait. So which of this is there is a problem with the gait? Then also which body part there is pain. You also be able to find out the level of pain using VAS. You have 0 to 10. You're able to tell which level of the pain is. Then I've mentioned also at the beginning that we'll have trial treatments. You try a treatment and see whether it's best for that patient. He's having pains, you have to change. He's having discomfort with it, you have to change. Doesn't show much result, you change. So you try. you make a lot of trial before you arrive at which treatments will you take. Then this is where I want to take us. Trial treatments, you could see their columns. Starting position. You apply you apply PNF. Which starting position did you use? Is it supine line, sideline? Is it in standing position? Is it while walking? You document it. The principles you have used in the treatment, we could see there is a column also for the principles. We could see for the techniques, which techniques you have documented, you have applied. You also document. Which pattern did you apply? You also document on those things. So you do before trial and after trial. So this is just in short about the documentation. So now we can take another technique. I hope we are not tired.
We can continue, sir.
Okay, let's take another technique. But for you, you want us to extend to another joint, not another technique. Well, now we'll go into antagonistic technique.
Yes.
We should pick antagonistic at least. So number one here, what I have is stabilizing reversal. So what is the goal of stabilizing reversal? Most of the antagonist technique, they are usually for strength. Most of them, they are for strength. So if you are looking for strengthening, you should look for the antagonistic technique. That's what I want us to take, even if it's one or two. So what is the goal? It's increase stability and balance, strengthening of group of muscles, coordination between agonist and antagonist. Because in the antagonistic technique, you are going to be involving agonist, antagonist. It's not like it's only one group of muscles. It is termed agonist is because only one group of muscles is involved. But here, you could involve biceps and triceps, triceps. So that's why it's called antagonistic. You have the agonist, you have the antagonist. So you could see here on the goals, you improve coordination between agonist and antagonist. What we have in combination of isotonic is coordination within the muscle. If you take bicep, it's coordination within bicep. If you take tricep, it's coordination within triceps. But now you have outside one muscle, you have involved other muscles. So now it's coordination between hamstrings and quadriceps. It's coordination between biceps and triceps. So that's why it's antagonist, because there's always antagonists while you are making movements, which is involved. So, like I said, the antagonists, they are for strengthening, but they are not the best. Just like we said, regime initiation is not best for coordination. You can use for coordination, but it's not best. Combination of isotonics might be the best. So this one too is not the best for strengthening, but you can use it. So what are the steps for this stabilizing reversal? It is possible to apply approximation to increase stability before starting. Start with better or stronger pattern. We have mentioned positive approach at the beginning at the philosophy. We have also mentioned you should start with eccentric, all those things, all these rules that you can start of which part. So switch to antagonistic pattern, comes without losing muscle contraction. End up with weaker pattern. So you start with stronger. You have biceps and triceps, for example. You want to apply or the shoulder, for example. You want to go into flexion. You want to go into extension. You go into flexion and extension. So flexion is weaker. Extension is stronger, for example. So you start with extension. You end in flexion. That's what they mean. You start with stronger pattern and you end in the weaker pattern. But you are going to be switching now. So end up with weaker. One of the hand of the therapy should be in contact all the time. And that should have verbal command. What we have seen in agonists, we don't change grip. All through are on the same side of the muscle. But here we are going to be changing grip. But it's not like you just hands off, then you do this. You hands off, you now change grip. You are going to be changing grip while there's always contact. You make sure that there's a contact here, then you change grip. You make sure there's a contact. You are maintaining the tension. then you change grip. Make sure there's tension, you change grip. You don't allow to lose the tension, then you change the grip. You lose tension, the aim has been defeated by that. So let's go through the steps. So from the name, stabilizing reversal, it's a technique that is purely isometric in a way. It's just to stabilize, the muscles are being stabilized, there is no movement. It's almost the same thing with dynamic reversal. Maybe we'll just take the two together. In dynamic reversal, there is movement. In stabilizing reversal, there is no movement. That's just one of the differences. So let's that's also
How should we change the side?
No,
if you are trying to listen. So now we are involving
anterior elevation, posterior elevation, most of them. You are involving both muscles, unlike the it's only anterior elevation or only posterior elevation. Now you are involving both of them. So what you have now is you move up, yes, hold. This is stabilizing reversal. Hold. Movement. Make sure he's holding in that position. Then change the grip. And ask him to go to your pressure. Push. Push. Now push up anterior elevation. Hold or you push rather. Push. Now posterior pressure. Posterior elevation. Now contact entry. I didn't just do this and now that tension was so that's the dynamic reversal. So solid, stabilizing. Then you see different names. like there is come to that. So if you see some text, you see some very different names. Yes, so that is stabilizing process. Push. And then dynamic process. You go to the bridge. Let's go up. Elevation. And posterior elevation. That is just movement. Next time we go to the village and come back. We go to the village and come back. Up. Yes. Up into anterior elevation. Up. Push back. Up. Push back. This one is movement. Push back. Up. Anterior elevation.
up. Yes, you yeah, no, yeah, dynamic. Push. Up. Up. And push. Landing program. Push. Push up. Up.
Not to allow any movements. Just you see, some some of the things, just like you mentioned, spasticity, sometimes one of the things you can manage them is you make a lot of fatigue. Then you can do other exercises. You also as the therapist will be different. Like that. I want to consider the offer of Muyabata. Want to look at the elbow. So we could see here on the picture, while going in the D1, while going to flexion, adduction, and external rotation, you see that the patient is making, you see on the picture there, you see the patient, the hand there is like a fist.
Yes. Okay.
You see it there? It's like a fist.
Going this.
While going into extension, then we have extension of fingers and the wrist and all those things. So maybe let's just break down. Let's just break it down.
have to follow these steps. See, into flexion, we have one, we have flexion, adduction, and external rotation. In the scapula, we have anterior elevation, and in the elbow, flexion and extension. Then forearm, we have, if you are going into flexion, you are going to have, right? We need to look at direction. If we are going into flexion, then we have supination, right? Coming back, we have rotation. So we are targeting into flexion. So we have flexion. No, the next sound. Okay, scapula, anterior elevation, shoulder. We have flexion, adduction, and external rotation. Flexion, supination. Then we have wrist flexion. You can see there on the picture, flexion of the wrist. We have radial deviation, and we have the thumb and the fingers also. Everything is flexed. So that's why the patient should be able to make this. You can see the picture of the instructor here. There is a fist. When you reach to this range, you see the patient holding his hand firm. So while coming back to the extension, like this, everything should be extended. The wrist extended, the fingers. Yes, and we have rotation, we have extension. Here we have opposites. Yes. Here we have extension. And here. We've been doing this. What the name? We didn't know the breakdown. As I'm rotating, the patient is supposed to make a fist and hold you. Then probably a deal resistance or whichever technique you are applying. Then you are coming back, close to half extension. So when you are starting, you start with the extended, then you go with the flexion. And it's going to, at the end, supposed to make the fist. That should be your target. The patient is able to do that to tell you, you're able to understand. Or you can go to other things and make sure it's able to make the fist, then you go on with that. But at the end point, it's supposed to have. So you can see, you make a fist and come back. So that is the normal timing now. You make sure, yes, what should be first, what should come first. Everything is set, it's in extension. Then I remember when they're teaching me, up to now, I can't remember, it's only in Polish language. So say panza, that's the fingers, and then make a fist, then wrist flexion, then rotation, and all that is. That's what it's done. Because I was in the midst of people that many of them are not exercising, and I have to practice. So that's the little. So you make a fist, then that's panza, just the fingers, then wrists, So that's the normal time. Follow it up with this sequence. Then the supination, the wrist, then probably the rotation is going on in the shoulder and up to the hip. And also right on. Essentially also with the, so that would be, I think we are already discussed the intentions, but not discussed. One the lower limb, yes. We have deflection. So we have anterior pelvis elevation. Yes. Anterior elevation of the pelvis. We have flexion of the knee. We have adduction. We have external rotation. Then we have hip flexion. Right? Sorry, knee flexion. Sorry. We have ankle. What should we have? Those flexion. Those flexion. Then toe extension also. Then we have plantar flexion. Extension of the toes. Knee extension. Hip extension. Abduction. Internal rotation. Then also have this flexion. And also toes also. Just flex everything. And here, downwards, and flex, just like this. Then so I technique you want to apply. You now apply. You will injection and combination of facilities. Let me try some. So let's go up. Yes. Yeah, giving him signal. So extend. Now, let me explain to you how. Now I'm going to resist you. Yes. I'm going to resist you. Down. Hold. Let's go up. Yes. Up, up, up. Hold. And down. Up. Down. No, you are just pushing down. I'm supposed to, yeah, you are supposed to resist my movement. Yes. Down. And up. Up, 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 up. Yes, let's go down. This condition of us is agonistic only. Let's just can do for the extensions. Yeah. So let's go down. Push. Push. And now you resist. Yes. We are going into internal rotation. There's also going to external rotation. Yes. And down. So I'm coming. Now push. Yes, push and resist you. Yes. Then yes. And push. Combination of tests. Push. Push. For example, timing for emphasis, issues with elbow, with wrist. You want to now focus. Combination of isotonic for supination and coordination. For example, this is where supination, coordination. Timing for emphasis now. Initial timing is to make sure you make this flexing. That's the initial normal timing. Thank you. That's normal timing. Time for emphasis, for example, that this is elbow, persisting, some coordination, other things. Then you just want to emphasize on Now we can go into combination of isotonics. Let's go. We are going against my resistance. Hold, then, and up, 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 up. We are resisting. I'm resisting, sorry. Now, and for one at any further part of wrist. While the problem, yes, you can also, I was going to be movement of wrist, fist, and yes, so this is right. Any other parts, we can look for emphasis. Say, okay, this is where the problem you have realized, this is where it's stopping the whole movement. Okay, let's focus on the supination, pronation, let's focus on the shoulder. That's time for emphasis. For ankle, yes, same thing. Yes, in fact, that's where you have just stopped, yes. Wrist, elbow is always the problem, and also this. You can just your fingers up and back. For example, yes, you wanted to go this whole way from the arm, hold up, but now it's just hold. Just maybe it's the knee you want to focus on. Do combination of isotonic works. You can also include the toes. Yes. Take also your toes up. Yes. You are pushing against my distance. Now let me push you against your resistance. Now push. And let me now push. Combination of isotonics for the ankle. Toes. The patient can resist the flexion. Let him go.
No. You see that you ask them to walk and they cannot. You see them, they cannot walk properly. So you have to work on that. For them to learn it, to also automate the function, and also when they are able to work, they should be able to automate it. That's when you see better gains.
I have a patient that I was telling him in the next visit, I'm going to discharge him, let him start going to the market. He used to sell things on. He will hold his basket and go like that. So while coming to the office, I observed that he's putting everything one side, one direction. Who is fun? He's working like this. You all stand there and he's afraid of falling. So while coming here, I observed that this session is only looking at the center of my table, not even the medicine to do what is like inside. He needs visual cue. I tried to check the balance. I just go and check inside. He's trying to lose it. Ask him. Check balance. If he close his eyes, it's going to fall down. Yeah, because you need visual cue to work. Yeah. What you do most of the time is you have a very simple. You can start from standing. Even the simple run back test. I'm sorry, we are debating the simple run back test. You stand, you close his eyes, you make one leg stance, functionalist test, you close eyes. So many other tests. I did balance assessment and the other trunk balance exercises. You can still do those things, but you have to also be alternating between with eyes open, eyes closed. Yeah, that's when you can learn those things. You can also give him some tasks also as he's walking. Yeah. For you to take his attention off this the eyes, yeah, to stop using the visual cue too much for the gait. You can ask him to do some calculations. You ask him as he's walking, you say count 1 to 10 as you're going. Or you ask him to count the steps with walking on, or you ask him to be able to make certain steps in a certain distance. You have to start thinking. Then that cue of visual now. And you see what. Yeah. But before going to that, you make sure you save the right state so that you are well for. But you can start with sitting, standing, forward. That's good. Most of the time, so patient now, you need
cognitive, too much cognitive inputs that take all their attention from it. If they are working, you ask them, Baba, in Afana, you have to stop. I will respond to you. Then you have to continue. If you talk and work, they are going to use further. Because it's putting other system to make sure it's balanced work. That's one of the problems. So you have to work towards that. You give dual tasks, you give dual cognitive tasks, you give all those things. Also train the balance, and from there you can win them for that system. Yeah. Solely dependent. Thank you. So, really need one, right?
Okay. Yes. Let's check for G2.
What is it? We call it
While he's relaxing in his room.
That was made me laugh. You can't hear anything. Yeah, I think almost 20 people have almost half of the platform were not. I know. That is always the problem with this PNF. That's why I decided to remove some things and just say, okay, let's look at this again. If I start everything properly, we'll have lost interest without going into techniques.
If someone is not understanding, yes.
Purely practical course, not too much theory. It's not like formats that have a lot of theories. I have a lot of things, but I'm not looking at one that will just look at. So I think if you can look at the pattern of because you have to make sure. So is valve flexion, abduction, and external rotation. Are you doing so? If you start is not so you have been here with us three workshops.
Shoulder
flexion,
abduction,
and external rotation. This is internal rotation. External rotation. So we have the opposite is external rotation, adduction, and internal rotation. Sorry, extension, adduction, and internal rotation.
Shoulder abduction. This is adduction, but is it flexion?
Extension.
Are you come from flexion?
Okay, since you are coming from flexion into extension. Yeah, I got it.
Is this flexion? Which one is flexion? Which one is let's say
shoulder. It has two flexion.
What is the definition of flexion?
Reducing joints.
How are you reducing the joints?
This is the joint.
If you do this, are you reducing or reducing?
It's just from where you abduction.
Flexion, abduction, and internal rotation. External rotation. Okay, we do like this.
What are the combination of the movement in?
I've already read it for you.
Oh, okay.
Flexion,
Flexion,
flexion, abduction, and external rotation. Flexion, abduction, external rotation.
yes.
Flexion,
Flexion,
abduction,
abduction,
external
external
rotation.
rotation.
Extension, adduction, internal rotation. This is B2.
With elbow extended.
Yes, this is elbow extended. You can have to elbow flexed. Okay.
What about this time?
Of this, you can have this. That's
Okay. So,
lower limb.
B2.
B2.
If
We have
it's coming from this, then it's straight on the down. Then you want to say, okay, opposite.
we have flexion, abduction, and internal rotation. Flexion, abduction, flexion,
Flexion,
abduction,
abduction,
internal rotation.
yes.
Internal rotation.
This is external, this is internal. Internal.
You make reference to the head of
Head of
femur. Where you get it. So we have extension, adduction, and external rotation.
Okay. This one is not going.
Someone extension, adduction, 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 and
internal.
external. Let's start with the flexion, abduction, and internal. Flexion,
Flexion, abduction, internal rotation.
is internal.
Yes.
This internal. Yes. Then coming from here. Then yes. Because it's also in there. Just like we have the one is in that one. So it's also in this diagram. This is the extension. Adduction. Yes. Adduction.
Adduction, extension, and
We
internal.
have, first of all, we have flexion, abduction, and external rotation. But this is supposed to be internal rotation.
Yes. This is internal. This is internal.
Then we have here. This is into extension. This is the diagram.
this is what?
External rotation. Flexion and adduction. Flexion, adduction,
Extension.
deep extension,
Extension.
adduction, and
External
external
rotation. So this
deep flexion
is internal rotation.
Yes.
You have flexion, abduction, and internal rotation.
extension, adduction, and external.
So you have posterior.
Yes, depression.
Yeah, it's a hip posterior elevation. You have posterior elevation. You have anterior depression. We are coming to the conclusion that
The movement of the hip is moving with the pelvis.
yes. Same thing that we have with scapula. Yes, same thing also. It's with that we have with the one, the same thing we have with the two. Okay? No problem. The hip is
Posterior depression.
no, it's anterior. Okay. Elevation.
And this is anterior depression.
Just look at it that it's coming back. It's not that it's being anteriorly response. This is posterior elevated, or it's coming back. Yes, it's coming back. So that's I think we have answered your
Yes.
we have added to
Yes.
so that you feel you are not just repeating last year's
Of course.
motion. Any question? Wonderful contribution. Yes. Contract relax. Okay, it's similar to that one. It's similar, but it's different. They are not. But there are lots of differences. Timing, you are give something and the muscle you target. Because for muscle relaxation, you want to make sure the muscle is getting tired. So, is it the same muscle? You want to make sure, is it the same agonist that you want to get tired? Or is it the antagonist you want to use to relax that community? There are even different all last control, there are different ways to apply it. Yes. Using the spiritual condition, the other principle, there are two principles for them. After today now. Something is sleeping. I don't want to have this opportunity to share it. But when I left with that, I promised to come to that to teach. Just see this. Several months, months, I couldn't go. 3 years ago, I started with some dimensions, but all of them, I started with class in the end, the end of the party, the work on this, all of them. So I stopped using the time because they do remember 2 days ago, the MSc students, I want to take a lot of this. Even it's something on the time table. But I realized that it is something. Then I was still very energetic. I was going by 8 then. I was going to go by 8 before they go to post 9, 1 hour on taking. But we couldn't do all of them stuff. I'll come and I'll be the university. So a bit stuff. Unless the biggest test, I started taking the Euro course in 2020. But I took only 2 tests. They're not that. So there are 2. So it's if you just said, I'm not doing this, are you around this? I'm not doing this. So we're doing so much everywhere. So they're able to get the last bunch, last session, you take the course for dimension. So I didn't take it. Not in this year, not this year. So we already shared in my family. But then we will organize time. Time. Like for me to get this. Maybe just teach one. And one thing is that it's also the pattern is also the expose all the things. That's you I know for long you have been present. I know you for long. I know you have been talking about it. I know we have been solving it. I know you have been solving for a very long time. It's not that you don't do that. It's just the work you have or every day sometimes you don't pass through classes, but it's actually also you want to do also want to see slides and I don't also have some slides. So that's why those are some people come Thank you very much. What also motivates me when you come from
Thank you so much.
There's a lot of questions.